and also to the right, and the stomach in the left abdomen, and the portal sinus on the right side of the abdomen. In the you can see the picture. There is left portal vein. Sometimes its branches also seen with the right portal vein. We can see any anastomosis present in between these two veins, and then the aorta, the inferior vena cava, and the stomach is also seen here. Along with this, we can see the portal sinuses too. The next view is an axial view. View 2. This is mean for the view 2 is an axial view that is slightly cranial to the first view. That is the portal sinus view. This shows the ductus venosus. Ductus venosus is a thin vessel that originates from the left portal vein and connects to the inferior vena cava in the cranial.
Completed 8 minutes.
So
you have completed 8 minutes.
Completed. So should I stop now?
Yeah, 8 minutes is up. Actually, 2 minutes is still there. You can try to finish it soon.
Okay. The view 3 is for the ductus venosus, and then view 4 and view from view 4 to view 7. We can see the heart area. Different heart areas can be viewed. View 4 is meant for the 4-chamber view. 5th view is for the left ventricular outflow. 6th view is for the right ventricular outflow, and then 7th view is for the 3-vessel trachea, and then 8th view and 9th view is in the section of supracardiac territory. This 7th view is 8th view is for the fetal thymus and thigh box, and then 9th view is for the subclavian arteries. All these views are taken, and they are taken and compared with the ultrasound images that we have taken before. And we can find that all these images, all the 9 images are similar to the ultrasound images taken before. And so then, and the mild bilateral ventriculomegaly has been confirmed in the patient. And the patient has been taken to treatment now. The baby's defect has been identified in the earliest stage, so that they can be treated soon. This is the main advantage of using this prenatal study. But though it is many ways, there are still some factors, some disadvantages of this system is that it is so expensive actually comparing with the ultrasound. The MRI is expensive, and it is large, and it cannot be it is not a best choice of imaging, like for in case of in accordance with the portable thing. And then though the main advantage is that some obstruction of the shadows, adjacent structures won't be there in the MRI images, and so the details we get in the MRI using MRI will be more accurate than that of the images in the ultrasound. That's all I concluded, ma'am.
Okay, Aishwarya. Ma'am, it's open for discussion. Juries, it's open for queries now.
Aishwarya?
Yes, ma'am.
So you have put efforts to prepare this presentation. So I would appreciate you for choosing this topic. The topic is good. All you should have done is just concised your presentation, you know. You could have put a lot of images and could have avoided putting a lot of text. And anyway, your presentation, like, you know, you were just presenting without memorizing. So that's something appreciable. Can you just tell me one, question alone? What are the legal requirements when it comes to fetal MRI or, antenatal scans, ultrasound. So what are the legal requirements that we need to fulfill before we go ahead with the imaging?
Yes, ma'am. The ultrasound is being proved to be the best so far, but the usage of fetal MRI makes it more accurate. Like the pictures will be more accurate than that of the ultrasound images. In the ultrasound images, there will be obstruction of the heart and large vessels, as I said before, heart and large vessels by the lungs.
One second, Aishwarya. I think you didn't get it right. What are the legal requirements? What you need to fulfill before doing these MRI or ultrasound? What are some legal requirements in an institution or in a center, in a scan center, wherever they do the ultrasound and MRI, particularly antenatal scans? No, like so. What is the legal requirement? Is there anything that needs to be filled up or documented? Before the study.
The patient is first thing, ma'am, and then as we the same way we prepare for the MRI, that patient should remove all his metal objects before getting into the.
Okay, let me come out with it. Are you aware of PCP and DT?
No, ma'am.
PCP and DT. Okay, Aishwarya. Anyway, good luck to you. I leave it to the other juries.
Yes, ma'am. Yeah, you can ask, ma'am.
What about regarding the scan time in MRI?
Scan time will be 30 seconds, ma'am.
30 seconds for? You mean the whole procedure?
No, ma'am. For the particular single thing, ma'am. What? Yes, ma'am.
Okay. So, okay, tell me which is more sensitive modality, like when you compare ultrasound and MRI?
Sensitive? I didn't get your point, ma'am.
So, which modality is better, ultrasound or MRI?
I would say that ultrasound, ma'am, because MRI is expensive. At the same time, it takes a huge lot of time when comparing with the ultrasound. But in the point of images, the MRI is better, ma'am.
Okay, but anyway, this is a very good topic. Okay, for the first time, even we are seeing this for the first time. Very good effect. But in your slide, no, there is more content. You have been putting more text, as ma'am said. No, better if it is more in the picture representation, it would be better. Okay, so it's very nice effect.
I didn't get many cases as possible, ma'am. So with the limited thing, I prepared it.
Okay, all the best.
Thank you.
Suresha, sir.
Once again, very, very good morning. I have no questions, madam, actually. I think, yes, you can proceed. Thank you very much.
So now we'll move on to the next presenter, Adi Lakshmi from Savita College of Allied Health Sciences on the topic non-contrast renal angiogram. Adi Lakshmi, I will make you as a presenter so that you can check it. Okay. Yeah, Adi Lakshmi. Can you share your content now? Is there any? Yeah. Okay. Now we are going to start the timer. Okay.
Yes, ma'am. Am I audible?
Yeah, you're audible.
Thank you. Good morning, everyone. Today, I'm here to present on the topic non-contrast MR renal angiogram. To begin with, non-contrast MR renal angiogram is a sophisticated method of imaging the renal arteries without the use of contrast media. Before moving into the topic, first let us see the anatomy. Kidneys are bilateral, bean-shaped organs. They are located retroperitoneally in the abdomen. It is supplied by the renal arteries, which arise directly from the abdominal aorta. This renal artery is divided into anterior and the posterior divisions. This anterior and posterior divisions are further divided into segmental arteries, and these segmental arteries joins to form the interlobar artery, and then it is further divided into arcuate arteries and into interlobular arteries, and finally into afferent arterioles. This is the non-contrast image demonstrating the intrarenal arteries and its branches. The most common indications for this study are potential donors, renal insufficiency, renal hypertension, and fibromuscular dysplasia. And the contraindications are cardiac pacemaker, aneurysm clips, cochlear implants, and hip prosthesis. Before the procedure, the patient is instructed to maintain milk per oral for 4 hours before the procedure, and the weight of the patient is checked. Written informed consent is obtained, and the patient is changed to hospital gown, and finally, MR exclusive screening is done. The equipment used in our institute is Philips Multiva 1.5 Tesla, and the coil used for this study is body torso coil. Once the screening is done, the patient is positioned in supine with head first orientation, and the landmark is kept at the level of the sternum. An air-filled bellow is placed around the patient's chest to enable respiratory gating. When the patient is positioned, 3-plane survey is obtained. The sequences used for this study are axial and coronal balanced turbofield echo and axial beat trans, which is balance triggered angiography non-contrast enhanced sequence. To acquire an axial slices, the planning is done in the coronal and sagittal planes. The position block is placed across the kidneys, covering from the diaphragm till the iliac crest. To acquire coronal slices, the planning is done in the axial and the sagittal planes. The position block is placed across the kidneys, covering the bilateral kidney and the renal arteries from anterior to posterior directions. The most important sequence used for this renal angiogram is enhanced inflow inversion recovery sequence. The trade names of different vendors are listed here. Now let us see why it is significant. Basically, it suppresses the venous flow and the static tissues, and it produces better spatial resolution, and it provides better visualization of intrarenal arteries as there is no enhancement of the renal parenchyma. This sequence is a respiratory trigger sequence where an air-filled bellow is placed around the patient's chest, and the air in the bellow moves back and forth during the inspiration and expiration. This movement is then converted into the waveform. In the acquired waveform, the scan acquisition takes place at the end of the expiration, where the respiratory movement will be minimal. To acquire an axial slices of B-trans, the planning is done in the coronal plane. So the position block is placed across the kidneys, covering from the upper pole of the kidney till the lower pole of the kidney. 3 saturation bands are placed, 1 below the imaging plane to suppress venous blood, and 2 on the imaging plane to suppress the static tissues. This is the acquired image of B-trans, which demonstrates hyperintense signals in the renal arteries by suppressing the background structures. Now let us see the intrinsic mechanism behind it. So consider this as a bilateral kidneys, and this is the artery and this will be the vein. In the artery, the blood flow will be from superior to inferior direction. In the vein, it will be from inferior to superior direction. So this is the imaging plane. Initially, a 180-degree RF inverting pulse is applied to this region of interest. This pulse inverts all the spins in the region of interest, including the artery, vein, and the static tissues. An appropriate time of inversion of approximately 1000 to 1400 milliseconds is set to suppress the static and the venous blood. Meanwhile, it also gives adequate time for the inflow of fresh arterial blood into the imaging plane. When this venous blood reaches its null point after inversion, an RF pulse is applied, and hence there will be no contamination of the venous blood, and the signals are received only from the arteries. This is a preparatory technique, and the signals are generated by using a 3D steady-state pre-precision sequence. Once the images are acquired, it is post-processed to maximum intensity projections. These are the parameters used. They are TR of 6 to 10 milliseconds, TE of 3 to 5 milliseconds, and a time of inversion of 1000 to 1400 milliseconds with a flip angle of 80 to 85 degrees and a slab thickness of 10 to 15 centimeter with a slice thickness of 2 mm. The major disadvantages of this study is that it is highly sensitive to artifactual signal loss that is resulting from the blood flowing through off-resonant regions, and it is restricted to volume coverage. The scan efficiency and the image quality can be degraded in patients with irregular breathing patterns. Moving on to the case discussion. This is the image of a healthy volunteer demonstrating the normal renal arteries. A female of 55 years came with the suspect of renal artery stenosis, and this is the B-trans image demonstrating a calcific plaque at its ostium, causing stenosis at its origin. This is the MIP image of a 59-year-old male, which demonstrates stenosis in the left renal artery. To conclude, a good understanding and knowledge about the imaging techniques and parameters will enable the technologists to produce optimal quality images, thereby paving the way for better diagnosis. These are my references. I would like to thank the organizing committee for giving me this opportunity. Thank you.
Juries, it's open for queries, ma'am. You can ask your questions.
Yeah, very good presentation, Ms. Adi Lakshmi. There was so much of clarity in your speech. So what is the patient preparation as such for this renal angio?
The patient is said to be in fasting for prior to the study for 4 hours. And the breath hold instructions also given to the patient that they must breathe in a shallow manner.
Okay. Can you tell me why fasting is required?
Because we are going to post-process the B-trans images.
Okay.
And the sequence we are using is a gradient sequence, steady-state pre-precision sequence, and because of which, if the patient is not in fasting, there will be we will receive the signals from the intestines also.
Okay.
As it is a T2 based sequence, and from the cord also we can receive the signal.
Are you sure? Are you sure that the patient should be fasting?
Yes, ma'am.
Okay. Not necessary, not really necessary. Okay, fasting is not really necessary. And you have already mentioned the disadvantage that there can be problems with the gating in certain patients with, not a regular breathing pattern. Okay, what will be the indications? You have showed some images with findings like stenosis and all that. What will be the indications? What will be the chief complaints of patients, or who will be the patients who are presenting to MRI for a non-contrast renal angio? Where is it more advantageous?
It is advantageous in case of chronic kidney disease with the stage of 4-5 stages. The extreme condition where we cannot administer contrast to the patient.
Okay, good. Okay, I just leave it to the other juries. Good, Adi Lakshmi. Good
Thank you.
Adi Lakshmi, it's a very good presentation. Have you ever come across any artifacts in these pictures during this non-contrast renal angiogram? What are the possible artifacts can be there?
Respiratory related artifacts like face mismapping artifacts can occur at times. If the patient cannot pull, or the patient does not have a proper breathing pattern, the respiratory, even though if we place a respiratory gating also, there will be a chance of that is a face mismapping artifacts.
Okay, then it's a nice presentation.
Thank you.
Okay, thanks. Sudesha, sir.
I have only one question actually. See that how many patients you have come across in our department till now, till date, like this non-contrast renal artery patients?
I have
Hello?
seen only one case, sir. I have seen only one patient till now.
You have seen. You have
I have seen.
only one patient. Have you seen or have you involved in the procedure? Have you seen only or you are a part of a team?
I have seen, sir.
Seen. Okay then. That's it. Thank you.
Thank you.
Thank you, Adi Lakshmi. Now
Thank you.
we'll ask the next presenter, Sumit Jha from Acharya Institute of Health Sciences on the topic coronary angiogram. Sumit Jha, I will make you as a presenter. Just check whether you can share your slide. Sumit Jha?
Am I audible?
Yeah, you're audible.
Is my screen visible, ma'am?
No, it is not yet started. Can you do it again? Yeah, your screen is visible now. Please make it a slide share, slide view. So make sure there is some pop-up window coming in your screen. Can you make it a slideshow?
Click on the home button. Click on the home button.
Okay, please turn on your camera, Sumit.
Sumitra, can you hear me? Yeah. You have to present it now. Click F5 or you can make it as a full screen. Yeah.
Sumit, please unmute yourself. Okay, are you ready?
So, am I audible now?
Yeah.
Am I audible now?
The timer is going to start now.
Okay. So, good morning to all of you. My name is Sumit Jha. I am from Acharya Institute of Health Sciences. My topic is coronary angiography. So, it is an effective, non-invasive method to image the coronary artery, that is the blood supply to the heart. The cross-sectional image generated during this CT scan can be reformatted in a multiple planes, and they can even generate a 3D dimensional that we can do in 3D volume rendering. CT images of this organ, bone, soft tissue, and blood vessel provide greater detail than traditional X-ray, particularly of soft tissues and blood vessels. So, what are we going to view first? So, the coronary arteries. Two major coronary arteries branches off from the aorta. near the point where aorta and left ventricle meet. These arteries and their branches supply parts to the heart muscles with blood. So there are two: left main coronary artery, also called the left main trunk. So it divided into circumflex artery and left anterior descending artery, that is LAD. And the left coronary artery supplies to the circumflex artery, supplies blood to the left atrium and the back of the left ventricle. And left anterior descending artery supplies to the front and bottom of the left ventricle and front of the septum. Then we have right coronary artery, that is RCA. It divides into right marginal artery and posterior descending artery. It supplies to right atrium, right ventricle, bottom portion of both ventricles and back of the septum. So we are going to image this anatomy with this coronary angiogram. Now, what are the indications? So suspected abnormal anatomy of the coronary arteries, non-acute angina, that chest pain, intermediate risk of coronary heart disease before non-coronary cardiac surgery, coronary artery bypass grafts, unclear or inconclusive stress test results, and then congenital heart diseases, and new onset heart failure with reduced heart functions. So what are the contraindications? So there are two types of absolute contraindication: is hypersensitivity to ionated contrast, that is the dye which will be using, and then pregnancy. And relative contraindication is irregular rhythm, renal efficiency, and hyperthyroidism, and then the breathing problem, history of allergy to the medication, and then metallic interferences. So what are the patient preparation? So before the examination, caffeine and smoking should be avoided. The patient should be for NPO for 6 to 8 hours. Viagra or any other stimulant medication, that should be avoided. Before the night of the examination, IV or oral beta blocker that is used should be used. So it depends on the doctor who is going to do that. So the doctor can also give it during the examination or before the night to the procedure. So first consent is taken and procedure is explained to the patient. Then the patient is told to be in the hospital gown. Jewelries, metal items are removed. If patient is breastfeeding, the time of examination, the milk should be kept before administration of contrast, because the baby will be fed the milk. So as I told earlier, the beta blockers will be used as per the doctor's decision. Either he can use in the night or just before the procedure, or 45 to 50. If it's oral, then 50 or 100 mg of metoprolol is administered. And if it's IV, then 5 to 20 mg at the time of procedure. So sublingual nitrates or nitroglycerin are given immediately before the procedure to dilate the coronary arteries, and a patient is put in the supine positions. And then ECG leads are attached. So to give contrast, we'll use IV way, and 18 gauge cannula is used at the flow rate of 5 ml per second. Training of breath holds to the patient is required, so we can have a good image and scan is initiated. Now there are two, without contrast and contrast. Without contrast, we'll be doing the calcium scoring. So calcium scoring is done to detect the calcified plaque burden as a coronary atherosclerosis. So preparation, no special preparation is necessary. Just caffeine and smoking is been prohibited. Contrast is not used. And the threshold for calcification is 130 HU for an area of 1 mm per square. Now radiation doses ranges between 12 to 16 MSP depending on the CT scanner and type of ECG getting. ECG control dose modulation system allows reduction exposure by up to 50%. Lower the KVP to 100 causes significant dose reduction. And a prospective gate window of 20% over diastole in patient reduces the patient can dose to 80%. There are two gettings. ECG getting is prospective ECG getting and retrospective ECG getting. Now, what are the risks? Risks are heart attack, stroke, arrhythmias, allergic reaction to the dyes, and the kidney problems. Now the aftercare. So it's a safe procedure, only a day care procedure, but some patient may have some difficulty due to allergy to the contrast, and IV line should be removed. Some side effect may be seen due to the nitroglycerin and all medicine that will be administered. Now that's it. Thank you.
Yeah, juries, it is open for queries.
Sumitra,
Yes, ma'am.
the organizers, a small request. I would rather prefer all the presenters to switch on their videos. You know, it's always
Yeah,
better. We are able
yeah.
to see the presenters.
Yeah, we have informed them, ma'am. Now
Yes.
everyone are the following one will be doing that.
Okay. Sumit, you were well within your time frame. Though your presentation is not complete, with all the required contents, two things I would like to appreciate in your presentation. It was very nice of you to, mention the radiation dose. The first point was the radiation dose that you had mentioned in the presentation. And then the second point was about lactating women, what they're supposed to do before the CT or the contrast administration. Those two things I feel it's a very good way of putting the more important vital details that are required for the patients to know. That is a very big concern for the patients. So that those 2 points are very good. Okay, now what is your role when it comes to CT coronary angio?
Ma'am, sorry.
What is a technologist's role in a CT angio, coronary angio?
Ma'am, I'll be ensuring that all these protocols are followed.
Okay, you will do the scan?
No, ma'am.
Who will do it?
The radiologist will be doing it.
Radiologist?
Yes.
You mean the doctors will come and do the scan?
No, ma'am. They will be there. I will be doing the scan, but they will be there.
Okay, so you will perform the scan under their supervision. Am I right?
Yes, ma'am.
Okay. So you have mentioned about the heart rate and the beta blockers. All that is fine. What about calcium scoring? Do you have any clue about when and where you will go ahead with the scans?
Ma'am, calcium scoring is done to see whether the arteries have developed the calcium, because in the arteries if it's normal, there will be no calcium deposits.
Okay. So what if there are calcifications? So what is the score that you will prevent, or you will defer from doing an examination? You will stop doing proceeding. You will abort doing CT.
I'll be doing the calcium scoring first, and then I'll go with the.
Yes. So if there should be a value, right? If it is less than that, you will do it, right? If it is more than that, you will stop. You will not do a coronary angio. Am I right?
No, ma'am.
You're not sure?
No, ma'am.
Okay. Can you just check on that? I'm not giving you the answer. There will be a particular value, the calcium levels. So if the calcium scores are
130 HU is the limit, ma'am. But it's not that if it's 130 only, there is calcification.
Okay. Just go back and check on that. Okay.
You
should have put more about the planning, the gating. You just mentioned it. More about the planning, the acquisition, your post-processing technique. Now it's a technologist forum, and you have a very major role as technologists. We have a major role in the post-processing. The scan is okay, fine, right? But then after the scan, there's a lot of post-processing there where we can exhibit our potentials, and our skills can be exhibited there. It isn't going to be the same for all patients. So you need to focus on that. And next time in your presentation,
due to time limit, I couldn't do it. Then yes, I could have used MIP and all.
Yes, I do get it. But at least you could have put one slide on it. It's just my personal opinion, okay? But anyway, it was a good presentation, Sumit. Good luck.
Sumisha, it's a very good presentation. Can you explain what is retrospective and prospective gating mechanism? Because you just while presenting, you just mentioned the word like retrospective gating and prospective gating. What is meaning of
Ma'am,
prospective?
prospective will be doing between 40% and 80% of the RR interval, ma'am.
Okay.
Is triggered by the ECG signal at the prospected mid diastolic phase of the cardiac cycle, ma'am, in prospective. And in retrospective, we'll be doing the ECG, ma'am. Retrospective, I'm not sure. Prospective.
Okay. Can you tell me any contraindication for beta blocker administration?
Ma'am, the heart rate might get slower than the usual heart rate of the patient. It may
No, for I mean, what are the clinical conditions you will not prefer beta blockers? Like there are some contraindication for administration of beta blockers, right? You cannot give beta blockers for all the patients. There are few patients who are contraindicated, no?
Yes, ma'am.
What are the conditions?
Ma'am, I'm not sure. I'll check.
Okay. See, there are
Hi, Mr. Sorry.
Yeah, sir, go ahead, sir. Yes.
Is it okay, madam? Shall I?
Yeah, sure, sir.
Yes, thank you very much. Sumit, good presentation. Yeah, I have only one clarification actually, Sumit. Increasing KVP, it increases the patient addition dose or decreases?
Sorry, sir?
Because you said that increasing the KVP is going to increase the dose to the patient or decrease the dose to the patient? Hello, is it I'm audible, Sumit? Hello. Sorry for that, and it is not audible to me. Sorry, carry on.
Subiksha, sir, shall we move to the next presenter? I think there is a network issue for Subiksha. I think so. Suresha, sir?
Madam, yes, madam, we can go to the next speaker, please.
Okay, sir. So now I would like to call upon the next presenter, M. Ramya from Thiravium Paramedical College, Teni, on the topic automatic exposure control. Ramya? Can you be a little bit louder? Ramya, actually your screen is not visible yet. It just shows sharing the content. Can I just check your network?
Yeah, you have to correct your network, Ramya.
Ramya, can you please turn on your camera too? Your camera is visible now, Ramya. I think there is a network issue for you. Yeah, Ramya, now it is visible. Just turn on the slideshow.
Okay. Good morning, Honorable. Present here I am Ramya, Trivim Paramedical College, Teni District. My topic is automatic exposure content. Introduction. Automatic exposure control measure the actual amount of radiation instant on the image receptor and terminate the X-ray production when the proper exposure is obtained. Exposure timer. Exposure timer uses variety of ways to control the length of an X-ray exposure. Various types of timers: mechanical, electronic, automatic exposure control, pulse counting. Automatic exposure control, also known as photo timers. The photon timer is a device that can detect radiation and in response to this, produce a small electric current which helps in terminating the exposure. Let's see the working principle. X-ray from the X-ray tube. X-ray from the X-ray tube and the patient reaches the image receptor. After the image receptor, monitor measure the X-ray received by the image receptor. A current follow in the circuit block which is proportional to the intensity of X-ray reaching the image receptor. It sends a signal to the generator to start or end the exposure. Types: ionization chamber, solid state detector, photomultiplier. Let's see the types. Ionization chamber. Ionization chamber are almost used as entrance type of auto timer. Come in many shapes and sizes. Ionization chamber working principle. X-ray entered to the ionization chamber. The hole pairs are electron created. The positive ion interacted to the cathode side, the negative ion interacted to the anode side and produce the electrical signal. The detector consists the ionization chamber field. Field selector switches the activator. The signal goes through the amplification and auto timer signaling and generator control, generator and X-ray tube. Photo multiplier and photo timer respond to the intensity of a light which reach it and allow the light to be coupled to a VMT which can convert the light signal to an electrical signal. Photo multiplier photo principle. Light shield, fluorescence screen, light gauge, photo multiplier tube, X-ray timer and exposure timer and X-ray generator. X-ray instant on the fluorescence screen. It emitted the light and followed through the photo multiplier tube through the light gauge. The photo multiplier tube convert the light signal to electrical signal passing through the exposure timer and solid state detector. It operates on the basis of radiation producing ionization in or near a BN structure. Solid state auto timer use BN junction techniques and other devices work on the basis of photoconductivity and could also be used. Advantage: small size, no X-ray beam absorption, consistent light response. Advantage of using AEC: take less time to set up technique, speed up exam, improve exposure accuracy as long as proper positioning is used. Lowest repeat rate, saves patient exposure, more consistency in intensity. From visit to visit, tech to tech, room to room, hospital to hospital. Disadvantage of using AEC. Technologies to come to depend upon system, and when it crosses, cannot remember manual technique. Overconfidence in system may cause technologies to become negligible and commit errors. If you are not centered directly over area of interest, correct, portables are in over. Easy to room can be out of scope. Good kind of being many repeaters. Conclusion. Exposure timers are said to be the invention in delivering the
Ramya, is it over?
Yes, ma'am.
Okay. And Julius, it's open for queries.
Ramya,
Ma'am.
it's a simple and neat presentation.
Thank you, ma'am.
I think you spoke what you have understood. Okay, I just have only one question. So in your setup, wherever are you studying or working? You're a student.
Yes, ma'am.
Okay, so how many equipments do you have which has AEC option, ma'am?
Equipment, ma'am.
Where you have seen it? Do you have you seen machines with AEC there?
No, ma'am.
So you haven't seen any, you don't have any machines with AEC option there?
No, ma'am.
So you have just learned. Yeah, so
Yes,
you have just learned it. Only theoretical knowledge, no practical exposure.
Yes, ma'am.
Anyway, it's a good presentation. So I don't have much questions to ask when you have not seen one. Okay?
Okay.
Have you seen mammogram? Have you been working in mammogram modality? No.
No, ma'am. Yes,
Okay. Okay, we can go ahead now. No questions.
Okay.
Yeah. Hi, Ramya. Have you heard about fluoroscopy? Have you seen or have you heard about it?
Yes, sir.
Sorry?
No,
You're not
sir.
say you're not heard. Okay. No, at least you please try to know actually in which modalities AECs are used. Okay. But anyway, what you know that theoretically, as Madam said, you have presented nicely. Thank you very much.
Okay, thank you.
Thank you, Ramya. Now we'll move on to the next presenter of the day, Ismin Naufa from Dr. MGR Educational and Research Institute, ACS, Madurai, Chennai, on the topic existing and emerging advancement in magnetoencephalography.
Good morning, ma'am. Am I audible?
Yeah, you're audible, Ismin. Now I'll make you as a presenter.
Okay, ma'am.
Yeah, now you can share your screen. You are a presenter now.
Okay, ma'am. So am I sharing it properly, ma'am? Is it visible?
Yeah, it is visible. Can you be a little bit louder?
Yeah, okay, ma'am. Okay, ma'am. Is it okay now, ma'am?
Yeah, it is okay. Just put a slideshow, okay?
Yeah, sure, ma'am.
Now your time is going to start now.
Okay, ma'am.
You can start.
Okay, ma'am. A very good morning to everyone here. I'm Ismin Naufa, doing third year BSc Radiology and Imaging Science Technology from Dr. MGR Educational and Research Institute, Chennai. I'm here today to address you all about the existing and emerging advancements in magnetoencephalography. So this is the overview of my session. To start with the imaging techniques of the brain, we know that traditional imaging techniques like X-ray, CT, and MRI just reveal the structure of the brain, and that too in some brain disorders, the brain structure looks apparently normal. This limits the use of these three techniques, and hence in such cases, we need to concentrate on the functions of the brain with the help of functional imaging techniques like fMRI, PET, and EEG. So functional MRI and PET scans, they measure the brain's function while the changes in metabolism happening inside the brain. But these two techniques have poor temporal resolution and they have no access to electrophysiology. And PET scans also involves the use of ionizing radiation, hence this limits the use of these two technologies. So, in order to create an access to electrophysiology, a new technique called EEG was developed, but this technique has low sensitivity and poor spatial resolution. Hence, a complementary technique to EEG was developed, which is called magnetoencephalography or MEG. So, MEG is a relatively new tool that is capable of looking at the magnetic fields generated by the brain naturally and localizing them back on the brain. So, this is the conventional MEG systems. These are usually enclosed in magnetically shielded rooms, which are made up of metals with high permeability, so that they can deflect the magnetic fields, the Earth's magnetic field. Because the magnetic fields generated by the brain are very small, they are in the range of femtotesla. So this helps us to detect those magnetic fields without any interruption. So yes, such small magnetic fields require high sensitive detectors to be detected. Hence, conventional MEG systems depend on superconducting quantum interference devices, which are called squid sensors in short. These work on the principle of Josephson effect and flux quantization techniques. And squid sensors are highly sensitive. They can detect up to 3 femtotesla. They have a high bandwidth, and also they offer a whole head coverage with the use of more than 300 channels. These sensors are enclosed in dewar. So, since squid sensors are superconducting devices, they require cryogenic cooling with liquid helium. Hence, conventional MEG systems are also called as cryogenic MEGs. And this makes the equipment look much larger too. So, the squid sensors limitations. This distance between the scalp and the sensor is around 2 to 4 centimeter, which greatly reduces the SNR. Fixed sensor location is also a problem because the patient needs to be still during the examination, and reference sensors for field nulling is used, which is it helps to remove the Earth's magnetic field, and also the requirement of cryogenic cooling makes the squid sensors very expensive. It is very important to know that MEG scans don't show the structure of the brain. They just show the activity of the brain. So what we do is we combine MEG scans with MRI scans, and then this is called as magnetic source imaging. This allows us to see both the structure and function of the brain together. And the most common and well-known clinical application of MEG is its use in pre-surgical evaluation and localization of focal epileptic areas in the brain, and also in cases with schizophrenia. The epileptic spikes are identified by the neurologist through visual inspection of the MEG data, but the disadvantage is that it is actually a time-consuming task. Hence, a new technique called MEG epileptic spike detection algorithm was introduced, which made it easier for the neurologist to detect the epileptic spikes. So, talking about the emerging advancement, detectors alternative to squids were developed, one of which is high-temperature squids, and these squids work with they operate with liquid nitrogen rather than liquid helium, and the distance between the scalp and the sensor was reduced to around 1 millimeter, but the problem is these sensors are under development. Talking about the second alternative, the optically pumped magnetometers, they are called as OPM sensors, and they don't require cryogenic cooling, and hence they are very advantageous and also very they are less costly. Microfabrication is possible with these kind of sensors, which is nothing but they can be miniaturized. So yes, now let me talk about the MEG systems, which are based on the OPM sensors. OPM sensors work on the principle of Zeeman effect, and these sensors can be directly placed on the surface of the head. Thus, it increases sensitivity by reducing the thermally insulating gap by getting the sensor more closer to the brain. In 2017, the first experiment was made with a single OPM sensor, and then in 2019, researchers developed multi-channel OPM MEG systems on which they are still working on. So to compare the use of squid sensors with OPM sensors, the use of OPM sensors greatly reduced the scalp sensor distance, and hence it helped us to improve the SNR. And also the sensors could be flexibly arranged around the head. So this means the patient can move freely during the scan. This made it very, very easy to handle kids who cannot be handled very easily. So, and then the use of reference sensors is not limited by the device size. And finally, since OPM sensors don't require cryo cooling, they are less expensive. So yes, in general, OPM MEG is nothing but a scanner that is wearable like a helmet during data acquisition. So this multi-channel OPM MEG systems contained 50 channels into which second generation OPM sensors were incorporated. And each of these sensors contained a rubidium vapor cell, which is an alkali vapor within a glass cell, and then a laser for optical pumping. That's why it's called optically pumped magnetometers. And then the onboard electromagnetic coils. Actually, the most challenging task the researchers faced while working with this multi-channel OPM MEG systems is that to remove the Earth's magnetic field. So what they did is they designed the biplanar coils which were placed on the either sides of the subject. These coils generated magnetic fields which were equal and opposite to the Earth's magnetic field. So this is how the OPM MEG system looks. In the middle, the helmet, into which the sensors will be placed. The information collected by the sensors will be sent through the electronic cables into the data acquisition system, and then will be fed into the acquisition computer. Additionally, we have the biplanar coils on the sides and also the MSR wall for, to remove the Earth's magnetic field. So here you can see a board-like structure. So this is how the biplanar coil looks. And then, yeah. The researchers developed two types of OPM mounting. One is the flexible cap and the other is the rigid helmet. The flexible cap is EEG styled cap with 63 sensor mounts, and the cap was made from elasticated fabric, and there were many plastic wires which were sewn into the cap in order to maintain the shape and also to limit the OPM sensor's movement. So the total weight of the cap was around 309 grams. So this is how it looked. And talking about the rigid helmet, it had 133 cylindrical mounts, and the helmet was made from nylon polymer. The total weight of the helmet was around 1.7 kg, which was quite large. So the results were compared with the results obtained from both these models were compared. The flexible cap was, of course, advantageous, but the problem was mild movements had to occur in this, in this type of model, which didn't occur here in the rigid helmet because. Since the helmet being rigid, there's no possibility for the movement of the sensor. So this made the rigid helmet more advantageous than the flexible caps. So yeah, since OPM MEG systems allow the patient to move freely, it was very easy to handle patients with Tourette syndrome and also Parkinson's syndrome. So the multi-channel OPM MEG system is a result of the efforts put by all these 14 researchers who were all from the University of Nottingham. Their contribution to the field of neuroscience imaging is very immense, and that should be definitely appreciable. So the first OPM sensors were manufactured by Q-Spin, a company in Colorado, which was further fine-tuned by Circa Magnetics Limited by joining hands with the University of Nottingham. So yes, the journey of MEG. Initially, we had cryogenic MEG system, and then came the single channel recording in 2017. Actually, the sensitivity while comparing both the system was very high with OPM MEG systems because it allows the patient to move freely and they are more closer to the brain. So the sensitivity was very high. And then came the wearable OPM array in 2018, in which the patient the patient's brain activity was recorded while the patient was engaged in some sort of a task like eating, drinking, or even playing too. And then in 2019, pediatric helmet was introduced with the concept of one size fits all heads. And then came the virtual reality MEG recording, in which the brain response was recorded by keeping the patient in different kinds of virtual environments. Then, in the end of 2019 came the second generation OPM sensors, which were much smaller than the first generation sensors. And then, and also another technique, like they combined OPM MEG systems with EEG and checked for the result. There was a bit disadvantage because MEG systems, OPM MEG systems allow the patient to move freely during the examination, but EEG is not. This literally disturbed the data. So that's why this was disadvantageous. And then talking about the currently available system is the 50-channel MEG recording, which one is the flexible cap and the rigid helmet. So talking about the helmet design, We had subject-specific 3D printed scanner cards. These were actually expensive, and also modified bike helmet for the kids. Currently available technology is flexible cap and generic 3D printed helmets. Talking about the sensors, the difference between the squids and the OPMs is that squids measure the magnetic fields generated radial to the head, whereas OPM measure the magnetic fields generated both tangential and radial to the head. And also the difference between the first and second generation OPM sensors is very obvious in this picture. You can see the first generation sensors are very big when compared to the second one, which is much smaller and lighter. So yes, these are the expected future work. Improvement of background nulling, even more better. And then the third generation triaxial sensors, which could measure the detect or measure the magnetic fields from the 3 orthogonal planes, and reduction in the size of the, weight of the helmet. Because rigid helmet was advantageous, but the only disadvantage was its weight. So researchers are still working on it. And also to get closer to the deep brain areas. Like we can place the sensor inside the ear or at the roof of the mouth so that they are very close to the deep brain areas. But these kind of sensors are yet to be developed. And also the use of OPM sensors in fetal magnetocardiography. These are the 5 expected future work. So then, yes, I'm almost to the end of my session. So the cryogenic MEC systems were more advantageous when compared to the other functional imaging techniques, and also it was less advantageous when compared to the OPM MEC systems. So OPM MEC systems, even though it has some significant challenges, it is a user-friendly technique, and I conclude by saying it's definitely going to rock in the field of neuroscience imaging in the upcoming years. So these are my references, and this is Sir David Cohen, who is an MIT physicist from Canada. The great man behind the entire concept of magnetoencephalography. So thank you so much for offering me this opportunity. I feel it a great honor to present my work here. Thank you once again.
Thank you.
And Naufa?
Yes, ma'am.
It's a different topic, entirely different terrain and an entirely different topic, but with relevance. What actually why did you choose this topic? What is your interest in?
Since the theme was based on the current trends in radiology, I went for the currently available topics.
Good. So do we have the latest one over here in India?
No, ma'am. Actually, the prototype is being developed, which is still on research. So they have not yet published it, ma'am. It's still in the University of Nottingham itself.
What about the one system? When it comes to the journey, you mentioned the type 2018. Is it available? What about Nimmans Bangalore?
Yes, ma'am. Yeah, that's why. Yes, ma'am. It's there.
Okay.
Conventional MEC systems are available there.
Okay. So, what is the main advantage of MEC?
Or
where will the patients? Which sort of patients will benefit from MEC?
Like patients we have who have unpredictable movement disorders, ma'am. Like due to for example,
Parkinsonism, you mean?
Yes, ma'am. Like also Tourette syndrome, ma'am.
So no, but what about in epileptic patients?
Yes,
in which sort of epileptic patients is this MEC useful?
It's just used in the pre-surgical evaluation, ma'am.
Okay, pre-surgical evaluation, right? What evaluation? Correct. You're correct. I'm just bringing you closer to that. So, what's evaluation in pre-surg before? Just pre-operative assessment. What are they going to assess?
So, like, where are the? Yeah, okay, ma'am. Actually, like,
I just want a specific answer.
Yeah, sure.
Pre-operative assessment. We generally do MRI, we do CT, they do an EEG. So, what is the necessity for MEG?
Yes, ma'am. Because it very accurately the areas in the brain which were responsible for the epilepsy or the seizures to occur.
So that is, you mean to say that the epileptogenic foci can be identified? Yes.
Yes, ma'am.
So that can be done even in MRI. But then where this MEG comes handy is where the EEG is not very conclusive, and and also this MEG has to be done immediately following a epileptic episode, so that spike, you can identify the foci which triggers the spike. So this MEG will be useful in preoperative assessment to identify the epileptogenic foci where an MRI is normal or where an EEG is not conclusive, or there are no spikes on EEG, but still the patient is clinically, having episodes of seizures, and they are trying to rule out something like MTS or TLD. So in that instances, this MEG will be really useful. Okay.
Okay, ma'am. Thank you.
Good one. Good delivery. Good.
Thank you, ma'am.
I have one question. Do you have any specific preparation for this procedure?
It's similar to MRI, ma'am.
It's similar to MRI. Okay, how it is different from your routine brain and MEG? Do you have any, you do EEG also? What is the base difference between your MEG, EEG and MRI brain?
It's like MRI systems reveal the anatomy of the brain, whereas these two techniques they give the information about the brain activity. So to compare EEG with MEG, the thing is that EEG detects the electrical signals which are generated by the neurons, whereas MEG detects the the magnetic fields which are further induced through those electrical fields. So the difference is about the magnetic field and the electrical field.
Okay.
Thank you, ma'am.
Yes, thank you. Suresh, sir. Sir, would you like to ask any questions? Thank you, Naufa. Thank you for presenting.
Thank you.
So now we'll move on to the next presenter of the day, Deepika S. from Sri Ramachandra Institute of Higher Education and Research, Chennai, on the topic comparison of arterial spin labeling technique versus dynamic susceptibility contrast enhanced. Deepika, I have made you as a presenter. Please check whether you can share your content.
Yes, ma'am.
Yeah, your time has been started now.
Okay, ma'am. Good afternoon, everyone. I'm Deepika, doing MSc Medical Imaging Technology at Sri Ramachandra Institute of Higher Education and Research. First of all, I'd like to thank the organizing committee for giving me this wonderful opportunity to present a talk on arterial spin labeling technique versus dynamic susceptibility contrast enhanced MRI in brain tumors. Let me begin with an introduction. The core of my topic is basically based on the topic of concept of perfusion. Perfusion is nothing but a fundamental biological function that refers to the delivery of oxygen and nutrients to the tissue by means of the blood flow. It is generally a passage of blood flow from the arterial supply to the venous drainage, and it is measured using a diffusible tracer, example a contrast agent, that can exchange between the vascular compartment and the tissues. As I'm going to concentrate on the two techniques, first let us see about the dynamic susceptibility contrast enhanced technique. It is an established T2 or T2 star weighted perfusion imaging technique which requires a bolus injection of gadolinium based contrast agent. Generally, the paramagnetic contrast agent, example a gadolinium acid, is used as an exogenous tracer which can able to quantify about the cerebral blood flow and other hemodynamic parameters. Whereas, on the other hand, the arterial spin labeling technique doesn't require the injection of a contrast media. It uses an endogenous tracer, blood water protons, which act as a natural factors present inside the body, provides a contribution for the quantification of cerebral blood flow. Generally, the DSCE relies on the rapid intravenous injection of a paramagnetic contrast agent. It captures the first pass of the contrast agent. Then the hemodynamic signals of the DSCE, the T2 or T2 star relaxation time, and it transiently decreases once the contrast is injected. This is because of this increasing susceptibility effect. Moving on to the other technique, that is the arterial spin labeling technique. It is that uses a magnetically labeled blood water protons as an endogenous tracer. Generally, this technique uses the blood water protons in the arterial blood. It labels the protons with the help of the RF pulses, and it provides a two set of images. One is the labeled image and other one is a controlled image. The subtraction between the labeled and the controlled images eliminates the static signal, and as a result, we can able to quantify the cerebral blood flow from the resultant signal. Let us see what is a labeled image and controlled image. The basic principle of arterial spin labeling technique is that there will be a labeling plane will be placed proximal to the imaging slab, which label the arterial blood water protons within the labeling plane with the help of the RF pulses, and it inverts the magnetization of the protons. These labeled protons migrate via the arterial vessels towards the brain, and after the post-labeling delay, these labeled protons are prone for imaging, and we can able to acquire the tagged and labeled image. Subsequently, on the other hand, the other set of images are acquired without tagging or labeling. This is called as a controlled image. As a whole, the subtraction between the labeled image and the controlled image, we can able to acquire the resultant perfusion weighted image, and in case of quantification process, we can able to acquire the cerebral blood flow of the ASL mapping. The static tissue signals are identical in both the sets, but the magnetization of the inflowing blood is different, and this difference provides the perfusion signal. There are various techniques of ASL. They are the continuous arterial spin labeling, pulsed arterial spin labeling, and pseudo-continuous arterial spin labeling. In our institution, we are using pseudo-continuous arterial spin labeling technique. Let us see this technique one by one. First is the pulsed arterial spin labeling technique. By the name, it indicates the arterial blood water protons is labeled using the short inversion pulses for about around 10 milliseconds. The labeling pulses are designed to invert the blood water that is proximal to the imaging region. The blood moving from the labeling region loses its label gradually through the process of longitudinal relaxation. Since it is a pulsed arterial spin labeling, it has a higher tagging efficiency compared to other arterial spin labeling techniques. Second is the continuous arterial spin labeling technique. It produces it uses a long and continuous RF pulses for about 1 to 2 seconds to induce the inversion in the plane of spins usually applied at the base of the brain. It has an advantage of providing a higher resonance than obtained with other techniques, and it has a disadvantage of increased specific absorption rate, and it requires a special hardware to be performed. Third technique is a pseudo-continuous arterial spin labeling technique. It has an advantage of continuous ASL's high SNR and pulsed ASL's higher tagging efficiency. It also uses a train of very short RF pulses that mimic the action of long continuous ASL pulse with much slower energy deposition. So the pseudo-continuous ASL technique was mainly introduced to eliminate the continuous ASL demand on the hardware and increase the SAR. The common parameter which is used to the common parameter lying between the dynamic susceptibility contrast enhanced technique and the ASL technique is a cerebral blood flow. Cerebral blood flow is nothing but is defined as a volume of blood that is passing through the given amount of brain tissue per unit time. The unit is expressed as ml per 100 gram per minute. The main aim and objective of my study was to preliminarily compare the arterial spin labeling technique and the dynamic susceptibility contrast enhanced MRI for the evaluation of intracranial brain tumors. In our institution, we are using GE Signa Architect 3 Tesla with a head coil of 48 channels. In this, the study is conducted retrospectively with a sample size of 10 patients conducted in our institution. The patients who underwent MRI brain tumor imaging and have acquired both ASL and the dynamic susceptibility contrast perfusion sequence were included in this study. The basic routine sequence for the brain is performed along with the axial 3D ASL sequence and the axial T2 or T2 star weighted perfusion sequences. These are the parameters which is used to acquire the ASL and the dynamic contrast imaging. Basically, ASL is an inversion recovery sequences which uses an inversion time of 1500 to 2000 milliseconds, whereas the dynamic susceptibility contrast enhanced technique uses it is a type of equiplanar imaging or the gradient sequences. After the acquisition of images, the freehand ROI was drawn on the axial plane by detecting the lesion on the perfusion map. The attention was to be paid not to place the ROI on the necrotic component, hemorrhagic areas, and the post-operative gliosis areas. These are the areas were excluded by placing the ROIs. Among the 10 patients I have collected, I have displayed a few cases where I have collected the cerebral blood flow value of patients who have undergone the ASL technique, and also I have collected the cerebral blood value of dynamic susceptibility contrast sequences with the same area of around 11.5 millimeters square with the patients with intracranial brain tumors. The correlation is drawn between the two techniques, that is ASL and the dynamic susceptibility contrast, and I have acquired a scatter diagram which shows that there is a true positive correlation between these two techniques. Then I have calculated the mean regional cerebral blood flow values of both the techniques of values respectively, and later the statistical analysis was performed to derive the correlation between these two techniques with the help of the Spearman's correlation coefficient. As a result, I obtained a p-value of less than 0.0034 with the correlation coefficient of 0.952, which implies that there is a strong positive correlation between these two technique values of cerebral blood flow. Since ASL can able to only measure the CBF parameter, the comparison study was done between only the CBF parameters of both the techniques. As a correlation result of all the statistical analysis, there exists a significant strong correlation between these both two techniques. Among the 10 cases, I have displayed some of few cases. This is a case of 68-year-old male with a known case of left parieto-occipital malignant space-occupying lesion. The findings implies that there is a heterogeneously enhancing residual mass lesion in the parietal lobe, and the various sequences displays the differences in the contrast in axial T1 weighted, 3D axial ASL, and the perfusion maps are obtained in both the technique for ASL technique and the DSC technique, and I have got the value by placing the ROIs within the lesion for both ASL and DSC technique. And this is a case of 17-year-old female girl with a bilateral vestibular schwannoma, shows a T1 iso-intense contrast enhancement is seen in the left cerebellopontine angle and the internal auditory canal, with showing the different enhancement pattern in the different sequence. And the ROI was placed within the lesion, and the CBF values for both ASL and the DSC sequences are acquired. Moving on to the advantage of arterial spin labeling technique, it has no injection of exogenous contrast media, so it can be used. This technique can be used in case of patients who are contraindicated to contrast agent, especially in case of pregnant women, in case of lactating mother, and in case of patients with known anaphylactic reactions. It produces the absolute quantification of the tissue blood flow. It is a reproducible and repeatable technique. The disadvantage of ASL technique is it has a low SNR, and only cerebral blood flow quantification can be done. The post-treatment optimization, automation, and standardization is still in development in the ASL technique. So I like to conclude that this study suggests that ASL can be considered as an alternative to dynamic susceptibility contrast enhanced in patients where the gadolinium-based contrast agent is contraindicated. It provides a beneficial information, the differential diagnosis of the intracranial tumors. These are my references. And I like to thank all the faculties for of Srihar for guiding and helping me to present this topic in this wonderful platform. Thank you, everyone.
Thank you, Deepika.
May I request the other two juries to intervene first, being our own student? I would prefer Suresh sir and Mrs. Akila to question them.
Thank you, madam. Actually, sorry that it was so nice presentation. Actually, speaking, there is no clarifications. Please go ahead, madam.
Yeah, I have one question. What about the role of ADC mapping in your brain tumors? Is it same or it is an? What about? Just tell me. Compare ADC with arterial spin labeling.
ADC produces values of areas with the restricted diffusion, ma'am. But it is ASL is generally used in case of where the contrast injection is contraindicated. It is an alternative tool in case where the contrast cannot be given, ma'am. So only blood flow quantification can be obtained using this technique, ma'am.
Okay. Okay, it's a very nice presentation with your statistics, data, and everything. Nice try. Thank you for the presentation. Okay.
Deepika,
yes, ma'am.
What you got from ASL is an absolute value. What you get from your T2 star perfusion is a relative value.
Yes, ma'am.
So how did you correlate these two?
Ma'am, I have collected the values based on the ROIs placed on the two perfusion maps, ma'am. So it is approximately equal to each other, ma'am. Since it is an alternatively, we can consider this tool in case where the contrast is contraindicated, ma'am.
Okay, but actually there's a formula to calculate it. That is your, regional relative blood flow.
Cerebral blood flow,
So
yes, ma'am.
I expect you to answer that. Like actually from the absolute value, like how you calculate your regional relative value. So you need to compare it with an ROI placed in the contralateral aspect on the where
White
do you place it?
matter, ma'am.
White matter. Yes.
White
so
matter.
that is how you calculate. Okay.
Okay. Yes, ma'am.
Good presentation.
Thank you, ma'am.
Now we'll move on to the next presenter, Dinesh Kumar C. from Sri Ramachandra Institute of Higher Education and Research on the topic flow diverter and web placement in aneurysms. Dinesh, I will make you as a presenter. Please check whether you can share your content. Yeah, you're the presenter now.
Dinesh, you're not audible.
Shall I start, ma'am?
Can you be a little bit louder, Dinesh? Your voice is not audible.
Now it's audible, ma'am?
Yeah, it is. Yeah, you can start. Your time starts now.
Okay, ma'am. Good afternoon to one and all present here. I am Dinesh from Sri Ramachandra Institute of Higher Education and Research. I'm studying BSc Honors Allied Health Sciences, third year. First of all, I would like to thank the organizing committee for giving me a wonderful opportunity in this forum. Today, I'm going to speak on the topic of the flow diverter and the web placement in aneurysms. The name itself, in sense, indicates that diverter is something which is a change in the path or the flow. So, flow diversion is a minimally invasive endovascular technique where a stent is placed in the parent blood vessel across the neck of the aneurysm. It is used in the treatment of the large and wide giant neck unruptured aneurysm. It is considered as an alternate to the aneurysm coiling. If coiling is used in a large wide neck aneurysm, then coil would get misplaced or dislodged from the aneurysm. So, aneurysm is a focal enlargement or dilatation of the blood vessel. The parts of the aneurysm is a dome, which is a curve-like structure, and a sac and the neck. What are the causes of the aneurysm? The first one is the atherosclerosis, which is the formation of the plaques within the blood vessel, smoking, heavy alcohol consumption, drug abuse such as the cocaine, and probability of the aneurysm increases with aging. Types of aneurysm. There are basically three types of aneurysm, which includes a saccular, fusiform, and the pseudoaneurysm. Saccular aneurysm means it is the bulging on only one side of the blood vessel. And fusiform instance indicates that it is a bulging on both the sides of the blood vessel. And pseudoaneurysm is there is only enlargement in the outer layer, that is the tunica adventitial layer of the blood vessel. And significance of the flow diverter and the web. It is helpful in the unassisted coil embolization techniques. It allows the treatment of multiple aneurysms, and it is considered as an alternative treatment for surgery. It promotes the occlusion of the aneurysm and clotting. Web, it overcomes the limitation of the thromboembolism and the hemorrhage, which is faced by the flow diverter. So it is considered as highly efficacious and safer than the surgical methods. So, flow diverter is a stent-like device that is deployed endovascularly to treat aneurysms. They would allow the blood to flow endoluminally rather than flowing endosaccularly. It is made up of a cobalt, chromium, or a nitinol alloy, and a set of the radiopaque wires together in a braid. Braid means it is a string-like structure. So it depends upon its porosity, metal coverage, and the pore density. So these, for example, I have put here a flow diota. The parts of this includes the base, a supportive layer, a healing promoter, and the proximal region, an extension region, a graft material, distal anchor region. There is a limitation of this flow diverter. It is less effective when these aneurysms are present in the arterial bifurcations. WEB, it is also known as oven endobridge devices. It is an intrasaccular braided embolization device to disrupt the blood flow at the level of the aneurysm neck artery interface. It consists of a nickel or titanium ball implant along with a delivery wire and a control. So these are the parts of the web. It consists of a distal recess, a distal marker, a microbraid, a proximal marker, and the proximal recess. It is indicated in the saccular wide neck bifurcation aneurysm with a dome diameter of 3 to 10 mm, neck size greater than 4 mm, dome to neck ratio between 1 and 2. So these are the indications for placing a flow diverter or a web. Vomiting, it may be a seizure, atherosclerosis, headache, blurred vision, and the loss of consciousness. So where it is contraindicated, for those patients who are under bleeding disorders and sepsis who are more prone to infections, and the patients with renal failure, pregnancy, and patients who are susceptible to allergic reactions. This is the equipment used in our department, Philips Allura Expo FD 2020. That FD 2020 stands for the detector sites. Since we have a biplane system, patient preparation, nil per oral is required 4 to 6 hours prior to the procedure, and metal objects should be removed from the region of interest. Coagulation profiles such as the bleeding time, prothrombin time, or the partial thromboplastin time has to be and the procedure should be explained to the patient. If possible, previous medical history has to be collected, and then the anesthetist fitness has to be given. So these are the materials used. It is a 6 French arterial sheath, which has the following components: a dilator, 18-gauge gel core needle, a sheath, and a guide wire. What is the main purpose of the 6 French arterial sheath? The sheath allows for the access of the multiple catheters in a single puncture site. And a 5 French vertebral catheter, Envoy 6 French guiding catheter, synchro guide wire, a 1.7 French micro catheter. Alternatively, we can also use the XT27 micro catheter, Traxxas guide wire, flow diverter. In our department, we are using surplus evolve flow diverter. And this is the contrast media used, Visipac 320 milligrams of iodine per ml. So pre-procedural diagnostic test has to be performed to reveal any presence of aneurysms or not, such as the CT angiography, MR cerebral angiography, and the digital subtraction angiography. Now, this is the procedure. The first step is to prepare the groin of the patient and clean with the betadine solution. The step 2 is under local anesthesia using cell Dinges technique, femoral artery is catheterized. Then the catheter is then advanced into the region of interest, and then the contrast is selective angiogram is done with the help of the contrast medium, and then locate the aneurysm where it is present or not. And step 5 is measurements have been taken for the neck ratio, dome to the neck ratio, and the size of the aneurysm to ensure what type of treatment has to be given. So, and then a 5 French vertebral catheter is replaced with the 6 French Envoy guiding catheter. And then a micro catheter is advanced into the guiding catheter to the aneurysm neck, where the flow diverter is deployed across the neck of the aneurysm. And finally, a high resolution intracranial stent CT and vaso CT is performed to confirm whether there is a full opening of the flow diverter or the web, and the arterial sheath will be left aside and it can be removed for later. What are all the complications of the flow diverter and the web placement? It can lead to a blood clot, rupture of the aneurysm, vasospasm, dislodgement of the flow diverters, damage to the arteries, and the improper placement can occur. Post-procedural care, removal of sheath and hemostasis. The staff who is working under there, so they should slightly gently press the puncture site to stop the bleeding, and check for the pulse, check for the pupils, and provide antibiotics if necessary. So I have taken some few cases which have been done in our department. So a 67-year female with complaints of visual blurring, DSA revealed an unruptured giant aneurysm. The patient has underwent a contour placement along with a flow diverter. Here you can able to see that this image is taken before the flow diverter has been placed, and this is the image taken after the flow diverter has been placed. Case 2, a 38-year-old female presented with severe headache and vomiting. DSA revealed circular wide neck aneurysm involving the left ophthalmic internal carotid artery. Patient underwent endovascular embolization with flow diverter. Here you can able to visualize the aneurysm. This is an image taken before the placement of the flow diverter, and this is the image taken after the placement of the flow diverter. And case 3 is the 67-year-old male with hypertension and severe headache with transient drooping of the eyelids. DSA showed unruptured basilar top aneurysm and a web has been placed within the aneurysm. So here you can able to visualize the aneurysm. This is the image taken before the placement of the web, and this is the image taken after the placement of the web. So finally, to conclude, flow diverters and web itself has shown to be a new approach with the potential to increase the scope for the treatment of the difficult wide neck complex bifurcated aneurysm. So the technologist should have a proper knowledge about the flow diverters and the web. And these are my references. Thank you. I would also like to thank all the faculties who helped me in doing this presentation. Since this was my first presentation, so they helped me to do this one successfully. Thank you.
Thank you, Dinesh.
Sir, Mr. Suresha, sir, can you go ahead? Being a SRMC student, I can be the last jury to question him. Mr. Suresha, sir. Okay, Mrs. Akila, please.
Yes, ma'am.
Yes, thank you. Madam. Yes, please carry on, madam. Please go ahead.
Sorry, sir. Please go ahead, sir.
Yeah, yes, sir. Go ahead, sir.
Go ahead. Akila, ma'am, you can go ahead.
I have one question, Dinesh. Okay,
Yes,
this flow diverter and this procedure you have described with the help of your femoral artery access, right?
Yes, ma'am.
Okay. Suppose if patient femoral artery is not palpable, you're not accessed through your femoral artery. Is there any other way of catheter approach?
Ma'am, we can
other
also,
than your femoral artery?
And also if possible means we can give it through I don't know exactly, but since I have seen only more of probably we will be using femoral artery, ma'am.
Okay. So to puncture femoral artery, do you use any other image guidance to puncture femoral artery?
We can also use ultrasound, ma'am.
Yes, okay.
Yes,
other than femoral artery, is there any other arterial approach? Okay, you go back and check and okay.
I'll check
okay, suppose femoral artery, it is not palpable, or if the patient have a problem in the femoral artery, you can go for other axillary artery or radial artery. I'm asking like that. Okay, you go back and check and let me know. Okay.
Yes, ma'am. I'll look for that, ma'am.
Yeah, sure. Sir, you can go ahead, sir. Suresh.
Dinesh, actually, I have no more questions. Actually, I have only one doubt: what is the major role of interventional technologist in interventional radiology? Could you explain briefly?
Yes, sir. I'll explain it, sir. Sir, first thing is the technologist. Actually, he will be the in charge daily morning you should have to calibrate the machine equipment, sir. Daily morning, at least in our department, 8 o'clock we will be calibrating the. So it is the role of the technologist to calibrate and to check the daily instruments like catheters, guide wires, etc. So to check the list whether there is everything or anything is missing. So you have to report it immediately if there is any stockage or missing is there. And also you should is responsible for that whether any instrument is very less. So you have to inform it so that it can be bought, sir. And also a doctor, when an interventional radiologist says that this is the procedure to be done, and we will be helping that. What are the equipments? They will be telling what are all the equipments to be used. So we will be preparing those extra equipments, and we will be assisting them, sir, during the procedure.
Well, Dinesh. Okay. Okay, then. Okay, carry on. Thank you.
Thank you, sir.
Dinesh,
Yes,
I
ma'am.
have 2 questions.
Yes,
Okay.
ma'am.
So you have the endovascular management, you have coiling, you have flow diverter placement, you have web placement.
Yes, ma'am.
So where you will go only for coiling when you know that there is an aneurysm, even if it's a wide-necked aneurysm.
Ma'am,
The interventionist decides to go ahead only with coiling and not a flow diverter or a web.
Ma'am, it depends upon the aneurysm size, ma'am. If it is a small necked aneurysm, then we can use the coils, ma'am, for those purposes. If it is a small aneurysm, we can prefer coils, ma'am.
Yes. Okay, so that is if an aneurysm is ruptured. If it's a ruptured aneurysm, then definitely coiling will be the first choice. Okay.
Yes, ma'am. Okay, ma'am.
So all this, web and flow diverters will be unruptured aneurysms. Okay.
Okay, ma'am.
Okay. And also your choice in wide-necked aneurysms. So you have put it in your own presentations, wide-necked aneurysms.
Yes,
web will be the choice because if it's an unruptured aneurysm, okay, when they put a coil, if they place coils, there can be chances that there can be other episodes of doing the procedure again because there can be dislodgement, there can be movement, migrate. The coils can migrate because the neck is very wide. In such instances, that is why we say in wide-necked aneurysms, you have an option of flow diverter and web placement. Okay?
Okay, ma'am. Yes, ma'am.
Yes. Okay. We shall go to the next topic, please.
Thank you, ma'am.
Thanks. Good presentation, Dinesh.
Thank you, ma'am.
The next presenter of the day is Kanishka Jonala from SRM Medical College and Research Center, Kattankulattur, Chennai, on the topic MRI in epilepsy of temporal lobe epilepsy, MR spectroscopy and T2 relaxometry. Kanishka, I made you as a presenter. Please check whether you can share your screen.
Yes.
Yeah, it is visible, Kanishka. Please unmute yourself.
Kanishka, please unmute yourself.
I hope I'm visible and audible.
I can barely hear your voice, Kanishka. Can you be a little bit louder?
Ma'am, am I audible?
Yeah, now you're audible. You can go ahead.
Good afternoon, everyone.
Please turn on your camera, Kanishka.
Ma'am, I'm unable to turn on my video.
Click start video. Kanishka, you can click start video so that your camera will be switched on.
Yes, yes, ma'am. Yes, sir. Am I visible?
Yeah, it is visible now. You can turn on the slideshow and you can start your presentation.
Good afternoon to everyone. I am Kanishka Jonnala, a third year BSc MIT student from SRM Medical College and Research Center, Kattankulathur. Today, my topic is MRI in epilepsy, temporal lobe epilepsy. In that, we'll discuss about some quantitative techniques like MR spectroscopy and T2 relaxometry. Before going to MR spectroscopy and relaxometry, I would like to give a brief introduction about epilepsy and imaging modalities, EEG, and also protocols. MRI is used to identify any serious disorders that may have provoked the seizures, such as brain tumor or atriovenous malfunctions. It can also determine the proper seizure type and syndrome. Information from MRI is used to evaluate the likelihood that surgery would be effective in controlling a person's seizure. Before going any further in MRI, I would like to give a brief description or introduction about epilepsy. What is epilepsy? A neurological disorder in which the nerve cells in the brain is disturbed, causing seizures. Seizures are individual occurrences of abnormal electrical activity in the brain. It may also occur as a result of genetic disorder or any acquired brain diseases such as trauma or stroke. What are the common symptoms of epilepsy? They are loss of consciousness, weakness, anxiety, staring, contraction and jerking of muscles, and confused speech. The causes of epilepsy are brain damage from prenatal or perinatal causes, defects in brain development, brain trauma, genetic basis, head injuries, and infections. In that, it also includes neurological infections. And some of the times, we might also not know what are the causes of epilepsy. So this is the epilepsy statistics graph based on age and gender. Usually the kids and old aged people are more susceptible to epilepsy occurrence, and also males are usually more susceptible to the epilepsy occurrence because of alcohol related seizures and also head traumas. Types of epilepsy, a broader classification. Epilepsy broadly classified into partial or focal, generalized, and unknown. Partial or focal epilepsy is more common, which is 60% in all the epilepsy classifications. Focal epilepsy means the epilepsy is only localized to particular part of the brain, and generalized epilepsy is overall to the brain. Temporal lobe epilepsy. TLE is a common type of focal epilepsy that occur in the temporal lobe on the each side of the head. Temporal lobe is the area of the brain that processes auditory stimuli, memory, and emotions. We can see here temporal lobe is located on either side of the head. And MTLE, mesial temporal lobe epilepsy, affects the inner part of the temporal lobe, manifesting in the hippocampus. This is the diagram of hippocampus, and hippocampal guide and the amygdala. MTLE is common type of epilepsy and is often characterized by the sense of aura immediately preceding the seizure. As we can see here, parahippocampal gyrus. Here, usually mesial temporal lobe epilepsy might occur. Hippocampus is very sensitive and vulnerable to the brain activity, and MTLE might cause a major blow to it. Imaging modalities for diagnosis of TLE. In earlier years, maybe CT would have been used around 2010 era, but now MRI is mostly used for epilepsy diagnosis. Other than MRI, we also use PET scan, SPECT scanning, MEG, and EEG. EEG has an important role in the diagnosis and classification of epilepsy. It can provide information for predicting the response to anti-seizure drugs and to identify surgically remediable epilepsies. When seizure arise in more mesial temporal lobe areas, the EEG may also show rhythmic slowing during seizure. These may be hard to diagnose unless a typical seizure is recorded on the EEG. This is the equipment that we use for EEG cap, and also there is a gel which is made up of urethane foam, which is used for efficiency in dispenses the electrical signal, and EEG is usually preferred to be done after the MRI because if the gel is still present on the head, it might cause some unusual artifacts in the MRI. So if the doctor prescribes for the EEG before the MRI, then a head wash is required. MRI in temporal lobe epilepsy. MRI can be used to identify serious disorders that may have provoked the seizure, such as brain tumor, atriovenous malfunction. It can determine the proper seizure type and syndrome. These are the images of axial, sagittal, and coronal sections of temporal lobe. This is a typical protocol for TLE. First, we have to take for any MRI scan, we have to take a scout X-ray, AP head scout, and then we would usually take T2 sagittal, T2 axial, T1 axial, T2 axial flare or 3D flare, T2 oblique, coronal, parallel and perpendicular to hippocampus, DWI with ADC mapping, coronal 3D spoil gradient echo T1, and etc. Quantitative techniques, MR spectroscopy. MRS is the best tool to non-invasively and quantitatively show alternations in metabolic level. It allows to collect the spectral information from the volume consisting of many voxels. MR spectroscopy, here we see the spectrum, how the MRS is represented in a case. The spectrum represents the radio frequency signals emitting the nuclei of different metabolites in the region of interest. This spectrum depends on signal to noise ratio and spectral resolution. In this graph, we can see the x-axis is represented by frequency and the y-axis is represented by maximum height of the peak. And we can see some metabolites here. They are lipids, N-acetyl aspartate, and creatinine and choline. Choline, it resonates at a level of 3.2 ppm. It is responsible in increasing the cell membrane synthesis, like when there is any tumor or more cell deposits, then it resonates. And creatinine, it resonates at 3.02 ppm. It is responsible for aerobic energy metabolism of brain cells. Occasionally, a reduction in CR peaks might occur in brain pathologies. And N-acetyl aspartate resonates at 2 ppm. Present in axons indicates density and viability. NAA usually has the largest peak in normal spectra. LIP resonates at 1.3 ppm. This is a case study. We can see proton MR spectroscopy with MTLE. These are the metabolic ratios. the ratio between NAA and CR is usually 2.0, but in abnormal conditions it might be less than 1.6. And for NAA and choline, normal ratio is 1.6, but in abnormal conditions it might be 1.2 or less. Choline and creatinine value normal ratio should be 1.2, but in abnormal conditions there might be greater than 1.5. T2 relaxometry. T2 relaxometry measures T2 relaxation time, an intrinsic tissue property. It may detect subtle pathologies, which is useful in lateralizing TLE even in the absence of hippocampal atrophy. T2 relaxometry is considered to be more consistent imaging finding in hippocampal sclerosis. Hippocampal sclerosis is most common pathological condition underlying interactable TLE. Quantification is more sensitive and can determine whether the abnormality is unilateral or bilateral. So than normal T2 technique, T2 relaxometry is preferred because of its more sensitivity and able to diagnose the hippocampal sclerosis very well. This is a patient with unilateral right-sided hippocampal sclerosis. The arrow mark which I pointed there, you can see an abnormality. Conclusion, quantitative MR imaging can depict the presence and lateralize the TLE with more accuracy than the conventional MR techniques. These quantitative MR techniques enhance the standard of visual analysis and also the diagnosis. The references I took are from AJNR website journals, MRI Masters, and there is also a book known as MRI and Epilepsy by M.F. Fraser and M. Knott. Thank you so much for giving me this opportunity, and I apologize for not including many cases because I don't have much access to them. Thank you so much.
Thank you, Kanishka.
Kanishka? Kanishka, can you hear? A good presentation, though you said that you were unable to access the cases, you still managed to present what is relaxometry and, about spectroscopy. Have you seen spectroscopy being done in the hippocampus and the relaxometry being done?
Ma'am, I couldn't get the access to...
No, that's okay. You couldn't access the cases. Did you see the technique? Have you done it, or have you seen it being done?
I couldn't see it, ma'am, because...
You couldn't see. So where did you collect all these contents from?
I'm just like, I have just been
references.
studying, right? Yeah, references.
Just references. So do you have an MRI where you study?
Yeah, yes, ma'am.
So do they do this spectroscopy and T2 relaxometry? Do they do it?
It is only MR spectroscopy is done, ma'am. Relaxometry, we don't have access to that. Yeah.
Okay, so next time, since you have the theoretical concepts now you have understood, next time it's better that you go and have a look at it yourself, how a spectroscopy is planned in the hippocampus, that is in their temporal lobes, and also how a T2 relaxometry is done. Okay, unless and otherwise you see it, you will not understand the application of T2 relaxometry. Okay, it's a good effort.
Thank you, ma'am. Thank you for understanding, as it is my first time presenting.
Yeah, it's for a maiden presentation, definitely your delivery was good. Definitely it was good. Okay.
Kanishka, can you tell me what is Hunter's angle?
Ma'am?
What is Hunter's angle? Have you come across the word? Okay, what are the various chemical metabolites you see in the spectrum? You showed some,
NAA, lipids, CR, and colon, ma'am.
Okay. So what type of, so what is your basic magnetic field strength you require to do a MR spectroscopy?
T, ma'am.
No, only 3T. What is the basic model you need? Basic magnetic field strength you need to do a MR spectroscopy.
I'm not
What
sure.
equipment? What equipment you have in your university?
G, ma'am.
G.
Yeah.
It is 1.5 Tesla, 3 Tesla. Have you seen the machine?
Yeah, ma'am.
Yeah,
I have seen.
So, what is the magnetic field?
Hi, Kanishka. Hi, Kanishka. Hello.
Hello.
Kanishka, it is audible.
Yeah, sir.
Yes, since it is your maiden presentation, actually, I don't have any questions. But as Madam said that whenever you get a chance to witness the procedures in your department, go there and learn.
Thank you, sir. Yes,
Is it
sir.
okay?
Yeah, sir. I'll do it, sir.
Akila, ma'am, is there any queries, ma'am?
No, ma'am. You can go ahead. Yeah.
Okay. Yes. Thank you, Kanishka. So now we move to the next last presenter of the session, Krishna Kumar from MGNCRI, Pondicherry, on the topic DTI for brain images. Krishna Kumar, now I'll make you as a presenter. Please check whether you can share your screen. Yeah, you are a presenter now.
Yes, ma'am. Is visible.
Okay, now we are going to start the timer. You can start your presentation. Just please be a little louder.
Oh, okay, ma'am. Good afternoon to everyone. Hey, Krishna.
Okay, you can start.
Okay, ma'am. Good afternoon to everyone. I am K. Krishna Kumar, BSc Medical.
Krishna Kumar, you're not audible.
Okay, ma'am. This session, I'm going to explain about the topic advanced role of diffusion special and advanced sequence of MRI. This is an overview of this study. In this study, in introduction, we're going to about three topics: diffusion weighted, diffusion tensor imaging, and spectrography, color coding of DT. Okay, and in survey, we're going to analyze the DT cases for 1 month, result of that survey, and final conclusion. First aim, the main study to explain about DTA and also explain the brain in a special sequence called a diffusion tensor. This analytical study taken in the month in 1 September to find which diagnosis is a feature. These analyses are taken in my introduction. First, we're going to discuss about diffusion weighted sequence. First, DTA obtain images used. Diffusion weighted imaging is for imaging that obtain image using chromium motion water molecule. Two types: isotropic diffusion, anisotropic diffusion. Diffusion weighted mainly useful to diagnose vascular stroke in the brain. Tumor characteristics are seen well in diffusion weighted sequence when compared to the other sequence. Image of diffusion weighted sequence of brain. Now we're going to discuss about diffusion tensor imaging. Diffusion tensor imaging was originally proposed by Dr. Peter Basser in 1994. It is first developed for only MRI. Diffusion tensor imaging is an MRI technique that uses anisotropic estimate the organization. Diffusion tensor imaging rapidly growing nowadays to visualize the white matter of the brain. DTI provide qualitative analysis of the magnitude and it has two main parameters. One is specific and another one is restricted. Restricted represent the qualitative analysis, whereas fractional represent the directionality of tools. Now we're going to see about fibrotractography technique neural tract by using the data collected by diffusion tensor imaging. The ability of fibrotractography to create a white matter fiber of the brain. It creates a 3D map of connective fibers of brain. This is an image of fibrotractography that you were seeing different colors. Color represents each fibers in the brain. Actually, fibrotractography from image using the mode RGB mode. RGB means red, green color. And color coding of the brain. There are different type of fibers are there. Each fibers represent as different. Red colors are indicating transverse fibers, green colors, and finally blue colors are indicating craniocaudal fibers. In some places of brain, one fiber overlaps the another fiber that will be appearing in three primary colors, red plus blue. That means transverse fiber overlap the craniocaudal. It appears magenta in color. Green plus red. That means posterior fiber overlap the transverse fibers. It appears yellow. And finally, green plus blue. Transverse fibers overlap the craniocaudal fibers. There is xeon in color. These are the color coding of DTI. Now we're going to discuss about clinical applications of DTI. It helps to assess the deformation of white tumor and destruction of white matter. It also helps to find the abnormality in dimension of. Right? It also helps to neurosurgeon to planning the surgery, and also it detects some disease like Alzheimer's disease, focal cortical dystrophy, multiple sclerosis. Then it helps to identify the abnormality in musculoskeletal and peripheral nerve pathology. So we're going to see about survey. These surveys are taken in the month of September in our institution. And 55 cases are done in September month. That 55 brain cases we put these for 27 cases. In the 27 cases, 4 cases are from seizure diagnosis, 2 cases are from multiple sclerosis, and 2 cases are from dysphagia, and 5 cases are from nerve pathology, 6 cases for CVS, 6 refers for cerebral vascular accident or death, and the remaining 8 cases from mass infection. This is an image of MRI unit of MGMCRI. In this image, you can see the advanced 1.5 Tesla Philips machine. This machine have an advanced feature of DTI. The above analysis are taken in this machine only. Now we're going to discuss about some diagnosis of brain. First, we're going to discuss about seizure. All are know about seizure. It affects the abnormal electric charge in the brain. It also interacts with normal of the brain. It affects some nerves like motor, sensory, and anatomical nerves. Right side, you are seeing the image of seizure in that the arrow mark indicating the abnormality. Then we're going to discuss about multiple sclerosis. It is a chronic disease. It is generally characterized by disseminated and demyelination of nerve fibers, and it also affects the central nervous system of the brain. Right side, you will see the image of multiple sclerosis. That the red arrow mark indicating the abnormality of multiple brain. Now we're going to discuss about dysplasia. Dysplasia means abnormal growth developed in brain in a place of stratified squamous. It characterized by cellular atopia and loss of normal situation and this image you can see the abnormality of dysplasia of brain. Finally, we're going to discuss about CVA, cerebral vascular accident. It means a stroke occurs in brain when the blood supply to the brain is completely stopped or disrupted, and it causes cells to die in brain. It also called ischemia stroke. Image you are seeing the abnormality of CVA. The result of this study, 40% cases are from seizure, 7% cases are from multiple sclerosis, another 7% cases are from dysplasia, 32% cases from 17% cases from the remaining 32%. This pie chart, we identify that yellow color indicating seizure, multiple sclerosis identifies green in blue color indicating dysplasia, red color indicating black color indicating nerve pathology, and finally pink color indicating. conclusion. From this study, we conclude that the mostly used diagnosis was mouse infection. After that, mostly the diagnosis was CVA. In the last decade, cyberstatics become known well to the white matter of the brain very well when compared to the other sequence. It helps to neurosurgeon to visualize and localize the anatomy of brain before and even during the surgery. Provide information to form fibrotractography. Fibrotractography is a method to form connective fibers in a three-dimensional technique.
Thank you, Krishna Kumar.
Krishna Kumar, it's a good presentation. Have you seen a DTI being done?
Ma'am, I will see, ma'am.
You have seen? Okay. Have you done post-processing?
No, ma'am.
No. Okay. Have you seen a post-processing being done?
We have an advanced, ma'am.
You're not audible. Can you be a bit louder, Krishna Kumar?
Now we have an advanced police. It's post-processing don't need.
Okay. But still you will have your role to play, right? Even if there's an advanced workstation, you will have to load the images and do a little bit of processing, right?
Ma'am, little bit of dissecting the unwanted.
Okay. Okay. Is there something that you would quantify from there, from the DTI? Would you derive some values from DTI?
Yes,
have you seen it?
You, ma'am. Yes, ma'am. Some medium that and all we take information like physics and all, ma'am. How much density they have, that and all we take.
No, not that. See, for example, you're doing a DTI. You will calculate how much diffuse, no, you will calculate the mean diffusivity, right? You will see what is the extent of anisotropy, right? So the fractional anisotropy values you will calculate. So there only the technologist's role is very, very crucial. We need to push the images to the workstation, and you should know where the pathology is and what tracks actually run through the pathology, right? Can you, you've put some anatomy, can you mention one or two tracks that you know? The fiber tracks?
Fiber tracks, ma'am, in and all happening. The connective fibers, it will be.
Yeah.
Or we can see.
Like, for example, corticospinal tract, corticothalamic tract, like that. Okay, so basic anatomy of the tracks you should know from where to where it runs, so that when you're doing the post-processing, you can keep your ROI from one point and drag it to the next point of the tract. And then you give a click button, the tracks can be demonstrated well. Okay. So, and how to place an ROI and calculate the diffusivity and anisotropy. But because in DTI, just running a sequence is very easy. The technologists will do it, but then you need to sit and do the post-processing based, as you said, multiple sclerosis and different indications. There will be a different role to play. So you should know that. Since you have the facility, might as well have a look at it and do it yourself. Okay, good.
Krishna Kumar, it's a very nice presentation for the first time you are doing, no? How many cases have you seen?
I've seen 2 cases.
As ma'am said, next time when you go for the posting, try to trace out the tracks also, okay? It is our role only. Okay, nice presentation. For the first time you have done very well, okay? Thank you, all the best.
Thank you, ma'am.
Suresha, sir. Suresha, sir, would you like to ask any questions? Thank you, Krishna Kumar.
Thank you.
So, due to unavoidable situation, our last presenter Asad Ali couldn't join. So, there are only 9 presentations in this session. I thank all the participants for their active participation. The prize winners will be announced later to the individual's mail ID. For further queries, you can contact us in the mentioned number and mail ID. I also thank all the jury members and I request you all for the faculty presentation at 2:30 p.m. and give you valuable evaluation. Thanks in advance. The participants can leave the session.
Do we wait, Ms. Radhita?
Ma'am.
Do we have to wait?
Children, ma'am.
Good afternoon.
Once again, I welcome you all for the afternoon faculty presentation session for this national level technical symposium. So we'll begin the session with the first presenter, Ms. Pavitra S. From Oxford Medical College and Research Center, Bangalore, on the topic photon counting detector. Ma'am, I will make you as a presenter. Please check whether you can share your screen. Okay. Ma'am, you're the presenter now. Pavitra, ma'am. to some technical issues, Pavitra ma'am couldn't join now. She'll join us later. Ms. Sharanya ma'am, can you able to present now?
Okay, ma'am.
Okay. The second presenter is Ms. Saranya from Father Muller College of Allied Health Sciences, Mangalore, on the topic estimation of hemoglobin on basis of Hounsfield unit in CT. Ma'am, you are the presenter now. Can you able to share the screen?
Okay.
Yeah. Okay.
Is that visible?
Yeah, it is visible now. It is sharing. Can you please turn on your camera, ma'am? Yeah, okay. You're visible, ma'am. You can start.
Okay, ma'am. Okay, very good afternoon, all. Here, first of all, I'm thankful to the organization committee for giving me a wonderful chance to present a topic here. So, coming to myself, I am Sharanya, lecturer, Father Muller Medical College and Hospital. Coming to my topic, here I am going to discuss about my thesis topic, estimation of the hemoglobin on the basis of the Hounsfield unit in computer tomography head trauma patient. So this is the overview, introduction, methodology, result and conclusion. Coming to introduction, as we know, computer tomography uses a computer to reconstruct cross-sectional images of the patient body tissue from the X-ray transmission through the thin slice of tissues, through thin slices. Okay, as that also, as we know, there is a Hounsfield unit which is also called CT number. It will show us the measurements. It will give us the measurement in density of the different tissue. CT numbers, that is also we call H unit, that is assigned by the computer, and this density measurement has valuable role in diagnostic purpose and management in certain diseases. Here, through this CT number and through this CT, I have done a study which I'm giving a brief introduction about that. Through this study, we have found that the average value of HU to predict the HB, and also through this HU, how we can utilize this HB value for emergency trauma setting, and also how we can make it as useful for diagnosing the hemorrhagic anemia. Coming to aim and objective of the study, to evaluate the correlation between the Hounsfield unit and hemoglobin in head trauma patients. And also coming to the objectives, to find the correlation between Hounsfield unit and hemoglobin among head trauma patients. And also to evaluate the gender-related variation and to estimate the HB value through HU. Coming to materials and methods, study design, patients who all refer to the routine CT scan at the Department of Radiology, Justice K.S. Hegde Medical Hospital, and study setting, Justice K.S. Hegde Hospital. Study duration conducted 1 year, that is from March 2019 to March 2020. And studied population was same, who all referred to the normal CT, routine CT scan, the history of trauma to the Justice K.S. Hegde Hospital, which is coming under NETE deemed to be university. And we used the instrument GE Brightspeed 16 slide CT scanner, and the sample size was 114. Sorry. Oh, ma'am, it's not moving.
One second, you just exit from the slideshow. just exit and then again try to share it.
Now share your screen, ma'am. You can share it now.
It's not able to share, sir, my group.
Change. Yeah.
Okay.
Right now, no?
So
Okay.
can I
Okay.
start? Can I
Yes,
continue? Okay. Study procedure. First, we took informed consent from the patients and the scan performed according to the routine protocols with the history of trauma. And we measured the HU values with the help of our ROI, which is available in the CT monitor. And ROI we kept in the internal carotid artery and the vertebral artery of the brain to obtain the HU values. And later, patient's laboratory report have collected within 12 hours with the help of the PAC system for the correlation purpose. Again, same problem.
Ma'am, can you restart the application? Can you go out and come back? Can you restart the PowerPoint application?
Sorry, sir?
Can you restart the PowerPoint application? Can you go out and come back?
Okay. Okay. So, can I continue, sir?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
This is the measure. This is how I measured the HU value and HU value with the right vertebral artery and left vertebral artery and right ICA and left ICA. And coming to the result, there was 114 patients. In that, 92 males and 22 females was there. Using statistical analysis, correlation of the HV with the HU values of right and left vertebral artery and right and left internal carotid artery was determined separately. And also correlation coefficient R value and P value for significance. And here we aim to prove that through the IC and vertebral artery density measurement can find out the gender related variation with the HB and HU and estimation of the HB through the HU. And also here we compared the Hounsfield values with the hemoglobin values. And patient HB level, we found that the patient HB level below 10 gram per deciliter, HU value of vertebral artery and internal carotid artery will reduce under 35 HU value in patients who all are between the age of 30 to 40 years. And also we observed and confirmed that HU value between 36 to 49 can be average range of blood density in male patient with normal hemoglobin value and 36 to 43 HU value for the females with a normal hemoglobin value. And this is the diagram for the diagram which I added in the result part to show the difference in measurement of hemoglobin and vertebral artery and IC artery according to gender. So the p value was less than 0.05. here I am showing that the relationship between the hemoglobin levels and outcome measures according to the gender. So this also the p-value was less than 0.05. This result exceeds that the positive linear relationship between hemoglobin levels and other outcome measures according to the gender. This is the table which included the multiple linear regression model to predict the hemoglobin based on the HU. So here through this table, the right vertebral artery is more significant to predict the HB based on HU in males. That is, p-value was 0.008. There is no any significant values we found for the females. And average blood density we found for the males and females to predict the HB, and we were unable to predict HB with an fine accurate value of HU. And patients with the anemic condition can be predicted through HU. Patient with trauma, anemic due to trauma, that we can find out through this HU related study. Coming to the conclusion, through this study, we are agreeing that we cannot find accurate HU value to predict exact particular HB value. But in our study, we got an average range of blood density in male and female, that is between 36 to 49 HU, and as I told, female 36 to 43 HU with the normal hemoglobin value. And I am sure that this study will be useful to confirm hemorrhagic anemia occurred due to the trauma. And also study confirmed that there is a positive relationship between hemoglobin levels and other outcome measures according to the gender, both irrespective of gender. Besides, finally, the study shows right vertebral artery is more significant to predict the HB based on HU in males. These are the reference. Thank you.
Thank you, ma'am. Juries, it is open for queries. Sheila, ma'am.
Yeah. It's Madam Sharanya. It's a good study. So have you submitted this as a dissertation, or
Yes,
have you
yes.
published it? Have you published it?
Yes, ma'am. Yes, ma'am. Published recently.
Okay, recently. Very good, very good. It's a good work. Congratulations.
Okay, okay, ma'am. Thank you so much. Thank you.
Yeah.
Sharanya, this is a very good presentation. May I know, do you done any confirmatory investigation, any other investigations, or only CT you have taken?
Yeah, only CT, ma'am. Only CT with the history of trauma. Only the history of RTA trauma cases.
Any lab investigation has been correlated or compared, like
that? Lab investigation, HB level we have taken.
You have taken. Is it corresponding or it is matching to both the reports, like your radiological investigation and lab investigation are matching?
Means, ma'am, I didn't get that.
Both are correlating or it is not correlating?
Yeah, ma'am, both are correlating. Last finally, actually, we planned to find out an accurate value for the HU, for the HB, to find out through HU, but that we couldn't found an exact HU value we can't tell for predicting HB. So an average range we can tell. Through this study, we found that the anemic patients.
Okay, it's a very nice try and nice workout also. All the best for your career also. Thank you.
Thank you. Thank you. Thank you, ma'am. Thank you.
Thank you, ma'am. Now we'll move on to the next presenter.
And ma'am, I'm sorry, very sorry, due to some problem I couldn't go smoothly. Sorry for that.
No issues, ma'am.
Okay, thank you.
We'll move on to the next presenter, Mrs. Pavitra S. from Oxford Medical College and Research Center, Bangalore. on the topic photon counting detector. Ma'am, I have made you as a presenter. Can you able to share the screen?
Is it visible?
No, ma'am.
Now?
Yeah, now it is visible, ma'am. Like you're sharing a screen, you need to share the slide. Oh, yes.
Now can you see my presentation?
Yes, ma'am.
Shall I start?
Yeah, yes, ma'am.
Good afternoon. I'm Pavitra. I'm working as a tutor in Department of Allied Health Science in the Oxford College, Medical College and Research Center in the Bangalore. First, I would like to thank the organizing committee for giving me an opportunity to present the topic on photon counting detector CT. So let me begin with an introduction. Since 1971, CT has been used widely in the diagnostic and therapeutic medical arenas because of its fast scanning speed, high spatial resolution, and broad availability. So in these 40 years, we can see that there is an extensive and continual technological development happening in the CT field. And we can also see there is an improvement in the detectors. So what is a detector? A detector gathers the measurement. Hello?
One second.
So,
Ma'am, you can start now.
A detector gathers X-rays, the number of X-ray photons reaching the detectors, which is transmitted from the patients, and it measures all the X-ray photons and it forms an image. So we'll see the evolution of detectors in the CT. In first generation, there's only one detector, and in second, multiple detectors around 30, and in third generations, 288. Newer ones like 700. It's arranged in arc, and in fourth generations, 2000. So as the slip ring technology developed, helical CT and dual source CT scanning are also made possible. So in this, we can see that in each generation, the detector has been changed. And when the detector gets developed, even the X-ray beam, that is from pencil to cone beam, it has developed to cone beam. And even the movements, translate, rotate, fix, everything is being developed. And even the detector material also plays a major role. Like scintillation crystals are used and xenon gas detectors are also being used. So now coming to photon counting devices. In recent years, photon counting devices which are capable of spectral imaging have been introduced as a part of an experimental CT system. This is not new. It is actually used in our nuclear medicine in SPECT and PET. It is actually mostly used in the SPECT and PET because the number of photons is very less in SPECT and PET, but compared to the CT, in CT it produces a large number of photons. So nowadays the Siemens and GE Philips, everyone are trying to incorporate this photon counting devices in the CT. So what is actually the usage? Before seeing the usages, first we see what is a photon counting detectors. It actually uses a direct conversion technology for X-ray detection that does not require a scintillator layer as in conventional detector. So the first image shows the conventional detector where it uses a scintillator. So when X-ray comes in contact with the scintillator, it produces the light photons. And these light photons gets converted into electric signals by the photodiodes. And this image shows the PCD, that is photon counting detectors, where we use a semiconductor. The material mostly we use the crystals are cadmium telluride or cadmium zinc telluride. So when X-rays comes in contact with the semiconductor, it produces an electron hole pairs, and where the positive moves towards the cathode and negative towards the pixelated anodes. And then the electronic signal is being produced. The main difference between the detectors is, here in the conventional we are using a scintillator, so indirect conversion is happening, and in this PCD a direct conversion is happening. And the other most important thing which differentiate the conventional from the PCD is the threshold bin. So imagine there is a tube bin, and this is a threshold. So this threshold value helps to differentiate. It separates the energies. For example, I'm keeping a 65 keV as a threshold. So whatever, since we are using a polyenergetic in CT, polyenergetic X-ray in CT, so whatever the lower the value, the energy of the photons, which is lesser than 65 keV, will be stored in the bin 1, and the higher than the 65 will be stored in the bin 2. So it is like separating the energy, each photons in energy wise. There are also like 4 threshold bins or also can be used. So the other differences between the conventional and this is that in conventional detector, it is also called as energy integrated detector. That is, it combines all the energies. But here it is not like that. In photon counting detectors, it actually measures each photon's energy and store it separately. So PCDC, it is photon counting detector computer tomography. So micro CT and preclinical CT scanners with very small detectors capable of phantom and small animal studies have been developed and evaluated. In 2010, a whole body research PCD-CT system was introduced. That was the first PCD-CT system capable of performing studies in human subject. So what they used is for studying a human subject, they used the dual source CT, where in this they used only single source but with the 2 detectors. That is, one is the conventional EID and the other is the photon counting detector. So the other advantage of this technique is that it provides a very great flexibility in adjusting the imaging resolution and the number of energy thresholds by combining the detector pixels and using different pairings of energy thresholds. So these are some of the data acquisition modes like macro, chess, UHR. UHR is actually used, this type of mode can be used for a very ultra high resolution, and this is the shape. In case of a chess mode, we can use a 4 threshold bins. So coming to the clinical applications, the main advantage of PCD is that it reduces the electronic noise. We know that there are 2 types of noise, quantum and electronic. So in first images, we can see that a conventional detector where we can see some noises and it is being reduced in the photon counting device CT. So what they actually do is the electronic noises will have a very less amplitude. So they will, in the graph, we can see that they are setting a counting threshold above the electronic noise amplitude. By this, we can exclude the noise and we can get only the good images by avoiding the noise. And the other advantages is that improved iodinated contrast to noise ratio and radiation dose efficiency. So we know that photoelectric effects contributes more to the attenuations of low energy photons, while Compton scattering is dominant effect that account for high energy photons. So PCD-CT system count each individual photons equally, regardless of the measured photon energy. So hence, the low energy photons contributes more to the image contrast for PCD-CT than for EID. So what they will actually do is they will select the energy, the photons with very low energies, because these actually helps in producing a photoelectric effect. That is, it gives a good contrast to noise ratio compared to the high energies. So with this PCD system, we can select a particular amount of energies and provide a good contrast to noise ratio. And it also helps in reducing the beam hardening effect. First image shows the conventional images which is acquired from the conventional detector, and see, we can see a darkening in the image. And this is a second image. In this, we can also see a darkening in the beam. It's getting hardened here because this is actually acquired from the PCD, but it is from the low energy. And the third image is also acquired from the PCD detectors, but here we won't be able to see any hardening because it is actually acquired from the high energy photons. So mostly the beam hardening artifact occurs because of the low energy, which gets attenuated by the bones. And because of that only, since there is a deficient in the amount of photons reaching that region, we are getting a hypo. So in conventional, we are able to see the hardening, and in the low energy, we are able to clearly see it because we are using only the low energy to view the images. But in high energy PCD, only the high energy photons are collected to form an images, so there is no hardening. And the other is the metal artifact. This is an image which is acquired from the conventional, and here we can see the reduction. It is acquired from the PCD detector. And high spatial resolutions. In this PCD CT, we have a UHR mode, which we saw before. So using that, we get a good resolution images. And here they won't keep any septum or grid or anything, because since it is all based on the photons and its energies, so the resolution is also, and plus we are using a pixelated anodes and very small pixels being used, so the spatial resolution is very high. And simultaneous multi-energy acquisition. Here first is the normal conventional images, and in this too it is where we can see the in the second image B, where the bone is being removed selectively, and here where it is being given the color mapping can also be given according to its energy. And here in the first image, it is in a conventional iodinated, and then the iodine map is also being given. So it is actually simultaneous multi-energy acquisition is like, for example, if I keep 4 thresholds, one can be for the low energy, second can be for the high energy, and third can actually helps to, maybe we can set a gauge according to the iodine, and the other one is according to the barium. So by this, we can get a multiple energy informations, which we can select it accordingly and get an image. So what are the challenges? The PCD technique is not without limitations. There are still several technical challenges that must be addressed to realize the full potential of PCD-CT. These include photon flux and limited field of view. Limited field of view is actually a fundamental problem, but they are trying to remove this problem by, they're trying to solve it by increasing the detector units. And then the last is the image noise. Because since if we use a multiple thresholds, what happens is each bin will receive a less number of photons. So because of the less number of photons in each bins, it will result in more noise. So to conclude, PCD-CT is an emerging technology that, compared with the conventional detector technology, has multiple advantages. Compared to the conventional, it really has a multiple advantage. But however, research into the development of PCD technology are sure to continue, so that the theoretical and demonstrated benefits of PCDs can be translated into a clinical practice. Thank you.
Thank you, ma'am.
Hello.
Organizers, we will respect and recognize and appreciate the faculty presentations. Good one, Mrs. Pavitra.
Thank you.
Really
ma'am.
good
Thank you.
effort. Good.
Thank you, ma'am. And it's a pleasure to present it before you and Akila, ma'am.
I'm so happy to see you again on the screen.
Thank you, ma'am. Thank you.
Come back. Good luck to you. Keep
Thank
up
you,
your
ma'am.
good work.
Thank you.
A very good presentation, Pavitra. Congratulations also to meet you nice in the open podium. All
Thank
the
you,
best for your
ma'am.
career also. Very nice presentation.
Thank you, ma'am.
Thank you.
Now we move on to the next presenter. It is Neha Gupta from SRM's MS Institute of Paramedical Sciences, Bhojpur, Bareilly. Our topic is Wonders of Physics, seen how the ultrasound waves move to the medical imaging. Ma'am, you are now the presenter. Can you please check whether you can share your screen? Please unmute yourself, ma'am.
Hello.
Yes, ma'am.
Hello?
Yeah, you're audible. Can you hear me?
Hello. Yes, ma'am.
Yeah, you're
I-
audible.
Okay, ma'am.
You can start.
Good evening to all. Good evening to all of you. First of all, I will thank you for that you have given me chance for presenting the topic. Now my topic is wonders of physics. Wonders of physics seen how the ultrasound waves boon to the medical imaging. So I will start from introduction. That ultrasound waves means where the ultra means higher or greater, and sound represents the mechanical energy which is transmitted by the pressure waves in a material medium, which is transmitted by a crystal that is known as piezoelectric crystals in the ultrasound, medical ultrasound. The medical ultrasound is having the frequency of greater than 20,000 hertz. It is just like a stethoscope to the radiologist to look interviewing conditions without ionization radiation and gives useful information to the clinician for better improvement in the patient. The second, I'm starting the history that medical ultrasound is started as an imaging tool in the second half of the 20th century, that is 1930s.
Sorry to interrupt, ma'am.
Experts create curriculum with physics named as.
Ma'am, you're breaking actually. Can you please check your network, ma'am?
I will check it out. Hello?
Yes, ma'am.
I am audible now.
Yeah, now it is audible.
It is audible?
Yeah, it is.
So the medical ultrasound is developed in second half of 20th century, which is about 1930s or 1940s, and the WHO with ICRI of Indian Society of Radiographers and with other members of education training created a curriculum with physics named as medical physics or radiation physics, which is a very necessary part of the medical ultrasound. Without the physics, we can't clearly understood what the
artifacts were going on, what the imaging we are getting from the piezoelectric crystal, piezoelectricity, that piezoelectric crystals which are used in, which we are using for that mechanical transmitting the waves of ultrasound. These were discovered by the Peary and Jacques Curie in 1880s. So first of all, we have to learn about the what is ultrasound, and we have to discuss about the ultrasound machine. So we have different components in that. First of all, that is transducer, which is the main part of that machine, which is also called as the heart of ultrasound machine. And second one is the knobs on keyboards, which are used for the which are used Hello.
Yeah, yes, ma'am.
Hello.
Can you hear me?
Hello.
Yeah, tell me, ma'am. Hello.
Yes, ma'am.
Yeah, you can
Ma'am,
continue.
signal is breaking here. So the keyboard is used for the fixing image, detecting motion, as well as the measurement of the area which we are going to. In the equipment is display unit, which is used for the image display unit, which is just like an LCD screen, which is connected with a cable, and which is connected with the cable and the amplifiers, which is converting the electrical signal into the digital signal and mechanical signal into the electrical signal for the image display on the screen. So for the medium, as we know that any sound will travel in a medium, they need a medium to travel. So we are using ultrasound gel as a medium and a close contact between the patient and the transducer. So these are some pictures about the transducer as well as the keyboard which is present on the equipment. So there are various type of transducers which we have seen here. That basically there are 4 types of transducer which is present in that. With firstly linear array transducer, phased array transducer, curvilinear transducer, endocavitary transducer, which are used in the normal cases, which are used here. And this is the image which is showing how the transducer is made with the piezoelectric crystal, which is used for the mechanical production of the ultrasound waves. So the basic physics and its need is very necessary, as I have told before, that without physics we are not able to diagnose, we are not able to easily understood what the thing were going on and how the image is forming in the LCD screen. So physics is a key point how to learn generation, propagation in a and interaction of ultrasound, as well as how the data is collected. So physics is a necessary part. So in the ultrasound imaging, we are using the pulse echo technique, which is the basic principle of the ultrasound imaging. When the ultrasound waves electromechanically generated and transmitted through transducer with piezoelectric effect propagate into a medium through the ultrasound gel, it undergoes various interaction processes like reflection, refraction, absorption, scattering, and redetected by the transducer and converted through amplifier into the electrical signal, then to the digital signal and displayed into the image displayed unit. The intensity of ultrasound waves or the frequency of the ultrasound wave which are expressed in decibels. Radiologists as well as ultrasound practitioners have good knowledge of physics to have good grasp of various opposing interests since appropriate decision must be made how to optimize the desired image characteristic or how to reduce the artifacts which are make a hurdle in the diagnostic. It shows great linkage between the basic physics and the imaging practitioners are emphasized to learn the basic concept related to the physics. So now we are standing out that image display, image acquisition and display unit, and how the image is displaying on the screen. So firstly, when we are using transducer with creating a medium with ultrasound gel to a body, so the ultrasound waves are traveling with high frequency or the low frequency, which are refracting back or reflecting back, which are recollected by the receiver in the transducer. So which is that collected and receiving that mechanical and converted into the electrical signal through the amplifier, which is traveling through a fiber optic cable to the display unit, which is used where the amplifier is also connected, which is converting the electrical signal into the digital signal and showing the image on the LCD screen. Finally, after that, we have various applications in the ultrasound. So we are using continuous wave ultrasound and pulse wave ultrasound. We have two methods of using, and one of the, as we know that ultrasound is not going to be giving a biological effect, but it will shows the thermal effect in the imaging to the patient. So in continuous wave ultrasound, the emission of ultrasound wave is continuous, and a separate detector is used for requiring the echoes or receiving the echoes. This is known as Doppler effect. And other than the pulse wave technique is used for the distance measurement. This cannot be achieved by the continuous Doppler. And in advance of technique, the ultrasound is used using both continuous and pulse wave Doppler to generate the 3D imaging or 4D imaging of the during flow studies. Practical uses of ultrasound is that we are divided as we know the ultrasound we are using, and we have different fields of imaging in body. So we are dividing the imaging by the means of transducer. Then transducer is also called probe. So where we have, as early we have known that we have four types of transducer: curvilinear probe, phase array probe, linear probe, and endocavitary probe. They have different frequency generating piezoelectric crystals are present in that, and they are used for different type of sonography, different type of ultrasonography or ultrasound imaging. As curvilinear probe is mainly used for the transabdominal imaging, and the phase array probe is used mainly for the cardiac and transabdominal imaging. Linear probe is a high frequency probe is used for the superficial imaging, superficial soft tissue imaging, and the last one is endocavitary probe is used for the endovaginal intraoral sonography. Other than we have different types of transducer are also present, like endorectal transducers, which is used for the rectum studies. The last and the final topic of my study is the safety measures in the ultrasound imaging. As ultrasound is non-ionizing radiation, hence no adverse biological effects have been observed under diagnostic conditions of exposure. These measures must be taken for reducing or removing artifacts during the image acquisition due to inadequate parameters, as well as enhancing the image quality. And these all things are measured by the quality assurance team or under the quality assurance and control program, which were conducted by the quality quality assurance officers in the hospital or in the centers also. Thank you.
Thank you, ma'am.
Okay, ma'am.
Ma'am, is there any queries? Questions you want to ask?
No queries.
Okay. Okay. Now we'll move on to the next presenter, Mansoor Ali P. from Father Mullah College of Allied Health Sciences, Mangalore, on the topic MR black bone imaging in acute trauma. Sir, we have made you as a presenter. Can you please check whether you can share your content?
Yeah, sure, ma'am. I hope I'm audible, ma'am. Is it?
Yeah, you're audible, sir.
Okay, can I start, ma'am?
Yes, sir. Yes, we can start.
Good afternoon, all. My name is Mansoor Ali, working as a lecturer in the Father Mullah College of Allied Health Sciences, Mangalore. First of all, I would like to express my gratitude to the organizing committee for giving a chance to speak here. The topic what I'm going to discuss here is a black bone imaging. So it is a very simple topic, very short topic. Black bone imaging, it is a technique that is used in MRI, and it is a radiation-free, as it's an MR sequence, it's a radiation-free sequence, which is used as an alternative to CT for evaluation of a particular thing, that is here it is a bony structures. So it's an MRI sequence or MRI technique, and of course it's a radiation-free. If it is an MRI, it's a radiation-free technique that is used as an alternative of the CT for the evaluation of bony structures. So especially that in cases of head injuries, traumas, etc. So this technique actually enhances the contrast of bone in the MRI scan. So we know that if there is a trauma, something is happened, most of the cases the prescription for the scan, that will be for the CT scan, because it will be easy for the assessing the fractures, and also the fractures, it will be very easy with the CTs. So what currently the MR system, the use of this MR system for the trauma cases, and especially for the bony injury cases, are very less. Now the black bone imaging has come, which has recently, it is not a new technique actually, but which is not widely used. Is using still, but it is not widely used actually. So this sequence will help us to imaging the trauma case also with the MRI without a radiation. So there's a potential harmful effects of ionizing radiations actually, which will continue to be, it should be highlighted here. And the radiation reduction technique, which is already started with a lots of techniques are there, starting with the low dose techniques. So this all are some technique that is in the CT only. So once, if we want to shift it from an ionizing radiation imaging modality to an non-radiation modality, this sequence will be helping us, but it has some limitation and we will be discussing here. So assessing acute pediatric head trauma, here we'll be concentrating more on the pediatric case. I'll explain you why it is. Here, the black bone imaging, they are able to detect the skull fractures nearly as accurately on 3D and 2D reconstructions of MRI images. So here the two pictures are, the first one is CT 3D and the second one is black bone MRI 3D image. So the same case is that we'll be discussing. What is the objective of black bone imaging? Why a black bone imaging is needed? The first and the main objective of the black bone imaging, that is reduce the radiation dose, reduction in the radiation dose. So why we need to reduce radiation dose? That is to reduce the biological effects. If you are reducing the radiation dose, then it will reduce the biological effect. The radiation, there is no any safe limit of dose or safe dose in radiation. Even if it is a very less radiation exposure to a person, there is a chance for the biological effect. So there is no safe radiation dose. So how much it is possible, we have to reduce, as much possible we have to reduce the radiation dose.
And there's an important group that is a pediatrics. So why it is pediatric means the first thing is that they are more sensitive to radiation, and the second thing is that they have a high age expectancy. So what their expected live or the age that is more comparing with the adult people. So if you are talking about a child with a 5 year, it's an average life expectancy in India. It is something around 69 points in that way. So they have almost a 64 years spent into live. So as much time there is a chance for generating the biological effects if the baby has got exposure early. So this is why these pediatric groups are very important. These are some review of literature, and it is not mainly focused on the backbone imaging. It's focusing on the radiation effects in the pediatric cases. So the first case, Salotti and the team, they had done a retrospective study with 180,000 patients, and there they said reported that increased rate of leukemia, and brain cancers after pediatric CT examinations with an average follow-up period of 10 years. So with the follow-up of 10 years, they done in 180,000 patients, there is an increased rates of leukemia and brain cancer. So this is after they had done a follow-up after 10 years. The next study by the Brenner and team, here they stated that the estimated lifetime risk of pediatric CT associated leukemia might become 1 in 7,500 and the brain cancer 1 in 1,000. So it means that there is a chances for the pediatric patients who is exposed with the radiation, there is a chance for them to get leukemia or brain cancer. It is not confirmation, there is a chance. And there are some other studies which shows out of 1,000 cases, after 10-year follow-up they are done, they find that 1 to 3% there is a chance for 1 to 3% are affected by the brain tumor, and 1 to 5 pediatric cases are affected with the leukemia. And one more thing is that usually once a baby is come for the CT, most of the hospital and some area where I visit, I have seen that the exposure is not, parameters are not for the pediatric. They're exposing the pediatric case with a normal adult protocol, which will increase again the radiation dose. Now we'll move to the black bone imaging. Here, the parameters of what is the black bone imaging. So it's a sequence actually in MRI. It's a 3D gradient echo sequence. So there is a 3D acquisition. And the flip angle is very low, that is 5 degree. Flip angle is very less. And why we are keeping this flip angle is actually to get the all the other fat and the water will be in a same gray shade, and we have to make the bone in a black color or hypointensity or black. So ideal flip angle for this is 5 degree. There is a lots of study has done with 1 to 60 degree of flip angle, and they finalized that the 5 degree is good and ideal for the black bone image. Cortical bone will appear as black or hypointensity here, and the surrounding tissues appears almost uniform gray. And the sequence will take approximately 4 minutes. So this is not for an entire MRI of the head. If a person want to do the black bone MRI, that sequence it will take 4 minutes. And if there is the rest of the head MRI has to be done, for that extra time will be. These are the parameters. TR is 8.6 milliseconds and D is 4.2, flip angle is 5 degree. Then slice thickness 2.4 mm, scan FOB 24 centimeter, face encoding and frequency encoding is 256, and receiving bandwidth 31.25. Now we'll see some case discussion here. In this case, there are 3 images. The first one is an axial CT image, and the second one is a black bone image, and the third one, that C, that is an inverted black. So we all know that in the CT, the bone will be appearing as hyperintense comparing with the hypointense soft tissues. And here is there is a discontinuation of the bone and fracture is in the air. So the axial CT image was non-displaced linear fracture, okay, in the right parietal bone, and also there is an extracranial soft tissue swelling. Now let's move to the B, that is a black bone image. So in the black bone image, as we discussed, the bone will appear as a hypointense area or black. So here the arrow mark showing that So here you can see there is an hyperintense or the soft tissue density in this part. So the continuation of hypointense bone is lost here. This is actually indicating the fracture here. And same one more image we have, that is a inverted black bone image. So inverted black bone image, directly the opposite of the black bone image. So here the bone will be appear as a hyperintense and there is a discontinuation. Here you can see an hypointense line which is indicating the fracture of the right parietal bone. Now the other findings, same finding you can see here also, there is an overlying soft tissue swelling. Now go to the next case here. So this again another one case, axial CT image. Here shows a small non-displaced linear fracture. So it is non-displaced linear fracture you can see here, but this area is actually the mastoid area. We can see the mastoid air cells also here. Next, the B, it is a black bone image. So in the black bone image also, it will be a little bit difficult to see, but here you can see the white line you can see here. So it is a fracture. And the third image, that is the inverted black bone. So here also we can see the fracture. Moving to the third case here, this is an 18-month-old female with multiple fractures are there in the posterior aspect. The first one is a CT image, very clearly displaced fractures and the segments can be seen with the CT image. And the next is that here the black bone sequence. So in the black bone sequence also we can see very clearly that fracture is it which is displaced, and even that small difference also we are able to see how we are seeing in the CT. Now the C, it is a 3D reconstruction of CT, 3D reconstruction of CT, which also shows the fractures, the arrow marks of the fractures. And next the D is a 3D reconstruction of the black bone MRI sequence. So in this 3D reconstruction and also the normal black bone imaging, we are able to detect the fractures. So I added here the CT images also for the comparison. So I hope all of you understood. Moving to the conclusion here, improved soft tissue bone contrast with a low flip angle. So that is a black bone imaging. There is an improved soft tissue and bone contrast with a low flip angle. And fat and water, it's a typing mistake actually. Fat and water signals appears uniform gray shades. So the differentiation between the fat and water or the tissues will be difficult with the sequence, and that's why the sequence is indicated for bony imaging. Cortical bone will be appearing black or hypointense and is identifiable from surrounding soft tissues. Now, next we are moving to the limitation. There are some limitations are there. Actually, this study, lots of study is conducted, but most of the study what is done, it's on the skull. So the other part is yet to do. Actually, it's pending. So don't know about the more data about the other bony structures like the lower limbs and the other areas or the vertebral bodies, etc. Then the bone and air combined area. So in the black bone also, we'll be able to see the air in hypointense or black color, and the bone also we are able to see here as a hypointense or black color. So where there is a combination of the bone and air, that area will be little difficult for the diagnosis. An example is a paranasal air sinus. These are my references. Thank you. If doubts, any queries you can ask.
Thank you, Mr. Manzoor. Respected jury, if you have any questions, please let us know, or else we can move to the next session.
Excellent presentation, Mr. Manzoor. Good luck to you.
Thank you, ma'am. Thank you.
The next presenter of today's session, the last presenter, Rashi Saraswat from City University, Ludhiana, Punjab, on the topic HIFU.
You, ma'am.
Rashi, I have changed you as a presenter now. Please check whether you can share your screen, ma'am. Yeah,
Yes,
it is
ma'am.
visible
I have
now.
shared my screen. Is it visible?
Yeah, it is visible. Can you be a little bit loud, ma'am?
Okay, ma'am. Is it okay, ma'am, now?
Yeah, it is fine.
Good afternoon to one and all present. Today, I, Rashi Saraswat, an assistant professor from City University, Ludhiana, is going to present my topic on high intensity focused ultrasound, HIFU. That is the advancement in the field of radiology, as ultrasound was earlier being used for only for the diagnostic purpose, but now we are using the ultrasound for therapeutic purpose also for treating the diseases. And ultrasound is being combined with the magnetic resonance guided procedures, that there is MRI, and that we are performing the procedures. So in the content, I have introduction, types, uses, equipment used for HIFU, procedure, magnetic resonance guided focused ultrasound, that is one of the types. Then the coupling medium, benefits and risk, comparison between HIFU and one of the other technique, that is RFA, radio frequency ablation. And the last is the references. So continuing with the introduction, HIFU is high intensity focused ultrasonography, in which we are using the focused ultrasound. Earlier for diagnostic, we were using a diverging beam, but in HIFU, we are using the converging beam that is being used to focus at a particular point, and that focusing helps the sound waves to create the heat. That focusing is thermally ablating the portion of the tissue that is destroying the intense heat, that is destroying the tissue using intense heat. Okay, and it is a non-invasive therapy, as we are using the non-ionizing radiation in ultrasound, so it is a non-invasive therapy. Secondly, the intense heat, what is the result of the intense heat being caused? That is creating the tissue coagulation. Tissue coagulation is the blood clot that is being created in the tissue, and for that the tissue factor is included, which is helping to stop the blood flow into that tissue, and as a result the tissue dies, and in the tissue dies, which is helping us to treat the pathology. Secondly, the result is necrosis of the tissue, the dying of the tissue. Then cavitation, that is one of the biological effect of ultrasound, but which we are using it for the treatment purpose, as cavitation is helping us to treat the pathological tissues. And the last is the heat shock in the cells, as we are providing the focused ultrasound, focused sound waves, that is creating the heat shock in the cells. For that, we are providing a particular temperature. We are maintaining the temperature of 70 to 80 degrees Celsius. That is a high temperature for the cells, and we can reach maximum to maximum 150, not beyond that, because it can create an effect. Biological effects of the radiation can be created, non-ionizing radiation can be created. So in this way, we are introducing the HIFU in the radiology field. Okay, HIFU was, if I talk about the history of high intensity focused ultrasound, HIFU was introduced by the Fry brothers. William Fry and the Francis Fry introduced HIFU. In 1942, they introduced a device, the first device that is being used for the high intensity focused ultrasound. Later on in 1992, it is being combined with the magnetic resonance guided focused ultrasound. So there are two types. First is the diagnostic sonography with focused ultrasound. We are also referring it as USG HIFU. And this only the ultrasound is being referred, that is being we are using the diagnostic ultrasound along with the therapeutic, that is focused ultrasound. The second is magnetic resonance guided with focused ultrasound. In this, the diagnostic ultrasound is being combined with the magnetic resonance imaging, and then we are working on the HIFU. Okay, the uses, we are using the HIFU for the medical uses for treating the neuropathic pain, uterine fibroids, prostate cancer, tumors of bone, brain, breast, liver, pancreas, rectum, kidney, and testes. Also, if I talk about the advancement in it, the advancement is they are still doing the research on the blood-brain barrier, to open the blood-brain barrier, as we are aware of that the blood-brain barrier doesn't allow some drugs to pass through it. So some treatment of the tumors can't be done because we are not able to pass the drugs through. So with the help of the HIFU, the researchers or the scientists are working on to open the blood-brain barrier, the triple B, so that the drugs can be passed on to the
to the tumor place at the location of the tumor, and the tumors can be treated on. So this is one of the research which is being still going on. It is being started since 1996 and but not being utilized on some person. Okay. The second thing in the cosmetic field, if I talk about for the skin tightening purpose, we are using the HIFU treatment. Okay. Equipment. As you can see, this is the equipment we are using for the HIFU. This is the HIFU transducer. This is different from the diagnostic transducer as it has an acoustic lens. The function of the acoustic lens is to converge the beam. In diagnostic transducer, we are using the diverging beam. In the next slide, I will be showing a diagnostic ultrasound probe. This is the diagnostic ultrasound probe. As you can see, all the three types of diagnostic ultrasound probe have a diverging beam that are not focusing the ultrasound. But if I talk about the HIFU transducer, in this we are using the acoustic lens. The acoustic lens helps us to converge the beam, and with the help of the converging beam, we are able to focus at a particular point. The sound waves are being focused at a particular point, and when continuous sound waves or sonications are being given, repeated sonifications are given to a particular point, their intense heat is created. This heat can be raised to the 70 to 80 degrees Celsius to burn the tissue. Okay, in this way we are treating the disease. The procedure, as I have discussed, high power ultrasound focused we are using. We are using the sound energy which are being focused at a particular point by raising the temperature to 70 to 80 degrees Celsius. Maximum we can reach for 150 depending on the pathology. Okay. Then HIFU uses sound energy, that is multiple sonications we are giving to ablate the whole affected area. Radiologists can prefer USG HIFU or MRG FUS. It also depends on the procedure you need to perform or the pathology which is present. If there is a need to use the MR thermometry, we are going for MRG FUS, but in USG HIFU, we are not having the clinical thermometry. So the advantage is we use the MRG FUS to perform the procedures. The last, if I talk about the principle for the procedure, the procedure principle is similar to an experiment we all used to perform in our childhood days, that we used to take a lens and then below the lens we used to keep a leaf, and from in the sunlight, when the sunlight used to pass through the lens, the leaf used to burn up. Okay, creating because of the high amount of heat focused at a particular point. Similar principle we are using in the HIFU. This was the principle, this was the experiment we were performing in the childhood day. This similar principle is applied to HIFU. The sun, here the sun is depicting in HIFU, the sun is replaced by a transducer, HIFU transducer. For the lens, we are using the acoustic lens that is being attached on the transducer. That acoustic lens is helping to converge the beam on the leaf, and the leaf is being compared to a pathological tissue or a tumor where we need to focus the ultrasound beam. At that place, the beam is focused and the necrosis, tissue coagulation, or the heat shocks are created, and as a result, there is a treatment of the pathological tissue. Now coming on to the next type, magnetic resonance guided focused ultrasound. This is also being referred to as focused ultrasound surgery or focused ultrasound ablation, as we are burning out the tissue. So, and secondly, we are combining the ultrasound with the magnetic resonance imaging, MRI. It is helping us to detect the MRI helps us to diagnose that where the pathological tissue is present. And if we need to give the contrast to detect the pathology, to how much extent the pathology has exceeded, for that we are giving the contrast media that is also being visualized through the MRI. And the treatment is being done with the help of the focused ultrasound that is using the HIFU transducer. So being both ultrasound and magnetic resonance imaging, being both non-ionizing radiation, we are calling it as non-ionizing radiation procedures because both are using the non-ionizing radiation. Similarly, it is a non-invasive incisionless technique performed under MR guidance. Okay. Also, it is being now treated as an alternative to the incisive and surgical treatment such as hysterectomy, tumor excision. Earlier for the hysterectomy, we were going for the surgeries, but now for the hysterectomy, we are using MRG FUS. as well as for the tumor excision for the treatment of the uterine fibroids, we are using MRG-FUS. For this, the unit for the MRI unit is different from the normal MRI unit because, as we know, MRI doesn't allow the electrical equipments that are not suitable for the MRI. We are not allowed to take that. But MRG-FUS, this unit is being created in such a way so that we can perform ultrasound also on the same examination table. We allow the patient to lie down on the MRI table, and on the same examination table, we perform the MRI scan. Then later on, we perform the focused ultrasound to undergo the therapy treatment. This is the image for the MRG-FUS. As you can see, a patient is lying on the MRI table. We have a positioning system. The positioning system helps us to detect the localization, localize the pathological tissue. The transducer we are using is the HIFU transducer, which is having a concave lens or the acoustic lens that is helping to converge the beam. In the red portion, you can see the converging beam. Degassed water. As degassed water is mentioned, this I will be discussing later. Degassed water is a coupling medium. As we all know, in ultrasound, we need a coupling medium to transmit the sound waves. Similarly, in this, we are using a degassed water. Okay. Normal water is not being preferred because normal water creates cavitation, and sometimes what happens if a large amount of cavitation is being created, that can lead to the delocalization of the ultrasound beam. So it can be a disadvantage for that. So for that, we are using a degassed water. Then we have a coupling pad, and the pathological tissue is the uterine fibroid that is being treated with the help of the MRG-FUS. How the MRG-FUS procedure is different from the USG HIFU, that is, in this we are giving multiple sonications, we are putting an IV line, and in MRG-FUS, as we all know, time to be completed. So that time plus the time taken for the treatment by the HIFU transducer, so it takes several hours. An IV line is placed to inject the contrast medium. In case of fibroids, a Foley catheter is inserted in the bladder to drain it. The transducer is positioned under the target tissue as I showed in the earlier image. Okay. Repeated sonications we are giving. Repeated sonications we are giving, each sonications last about 15 to 20 seconds. Okay. The time can decrease also depending on the pathological tissue and its physiological or the metabolical function, that what is the physiological function of that pathological tissue. So on that, depending on that, the sonication time can vary, as well as the size of the tissue. The pathological tissue, the size of the pathological tissue decides the sonications time. Okay. It might happen that we have to treat the larger area of the tissue. So for that, we are doing the we are providing the sonications in the desired steps. At first, we will be providing the sonications at a particular point where it will be focused. Then it will be tissue coagulation will be there. Then we will be moving to the next position for the for treating it. Then later on, we will be moving to the next position. Similarly, we are using the desired steps to move on to kill the larger size of the tissue. Okay. We will be repeating the procedure till the target tissue is completed. If the pathological tissue still remains, we keep on providing the sonication. Also, it might happen in some cases that we might send the patient after performing the ultrasound HIFU with the magnetic resonance. First, we will diagnose with MRI, then we will provide the treatment. And in the end, again with the help of the MRI, we will be checking out that whether the tissue has been treated completely or some portion is left. If the sonications for that day is limited or the temperature is raised to such level that it can now create a biological effect, so for that we will send the patient back to the home. But later on, we can schedule another session for that, and the patient can be called upon on the another day. So it is safe as we are using non-ionizing radiation. So, but chances of calling the patient is less as compared to the other procedures. Now, in some cases, we are providing the contrast media at the end once the procedure is completed to make sure to get an assurance that the complete tissue has been destroyed or some part is remaining. coupling medium. The coupling medium we are using for ultrasound is the same we are using for HIFU. HIFU requires a coupling medium, okay, to pass on the HIFU energy that is generated by the HIFU transducer to the human body. At high intensities, we are aware at high intensity, the cavitation is created in the coupling medium. So interference with the cavitation of the sound waves can reduce their intensity. The first disadvantage is this, and it can defocus the beam. So if a beam is defocused, if we have, so the delocalization can be there. The focusing can be moved on to the other place, which might lead to the improper treatment. As a result, it will block the propagation of energy into the body or accumulate it to some other location, or we can say it might locate it to the some healthy tissue instead of the pathological tissue. So for this to find an alternative to this, we are using the degassed water. Degassed water is used. Degassed water is prepared by dissolving oxygen level less than 3 parts per million. Okay. In this, a probe is there and the fluid circulation system is there. As heat is being created, the fluid gets heated up. So to remove that heating thing, a chiller is used. The chiller helps to reduce the temperature of the fluid, and the degasser is used to remove the dissolved gases from the fluid. Also, a fluid adjustment member is present to maintain the fluid level in the coupling medium. Benefits of HIFU: it is non-invasive, non-surgical treatment, less risk, no ionizing radiation, faster recovery time. As all the above points I have said, non-invasive, non-surgical, all are combining to give us that why the faster recovery time is fast as compared to other procedures. Then precise treatment, because we are focusing to a particular pathological tissue. We are not disturbing the healthy tissues, only the pathological tissue is being disturbed. So a precise treatment is there. Required single session of treatment. There are very less chances that repetition, like the radiotherapy or the chemotherapy, we are calling the patient for the repeated sessions. So only single session of treatment is needed. As everything has a positive side as well as the negative side, similarly, it has some risk also. Non-target specific sonification. Risk is if you are unable to target a particular pathological tissue, it can lead to the burning of the tissue, healthy tissues nearby present. It might happen that the heating, if you need to provide the 25 degrees Celsius temperature or the 50 degrees Celsius temperature, but you are not able to provide that, it can lead to the incomplete destruction. The third point is it can, as we are creating the heat in the patient's body, so it can lead to the skin burns, which can be minimized using the ice packs. Then when we are using contrast media, there can be contrast media reactions. So for that, we have to take the history for the from the patient, that whether he is allergic to contrast media or anything. Second, the last is it can cause numbness or temporary sensory loss. As we are continuously providing the sonications and the sound waves and a large amount of it, it can create the numbness or temporary sensory loss, which can be regained back. The last slide states the comparison between the high intensity focused ultrasound and the another advancement of radiology, that is radio frequency ablation. In both we are ablating the tissue. Okay, so in this in HIFU, we are generating the heat by focusing the ultrasound. If we talk about RFA, in that I am using the radio frequency, alternating current to create the heat. In HIFU, we are able to focus the treatment area. In RFA, the healthy tissues are also affected along with the pathological tissue. In HIFU, there is a depth penetration, a good depth penetration. We can penetrate the sound waves to a good depth of the tissue, but in RFA, we cannot penetrate to a good amount. Then in HIFU, there is no direct contact required. In RFA, there is direct contact required. In HIFU, there is precise and fractional heating. We are giving the sonications in the breaks, 15 to 20 for one sonication. If we are providing for 15 seconds, then we will be taking a break. Then we will be providing the second sonication. So it is for a fraction and as well as for a precise time. But in RFA, we are continuously providing the heat. A large amount of heat is being provided that can lead to a large amount of risk factors. In HIFU, there is a single treatment, single session is required. In RFA, we need several sessions. So this was for my topic, HIFU. Thank you. These are the references. I thanks the organizers for organizing this platform for all of us to give us the opportunity to present our topic. Thank you.
Thank you, ma'am. Good, Rashi, good presentation and good comparison in the last slide also. More of pictures could have helped better. The content was really good, but more of pictorial explanation would have been better in my opinion, but it was a wonderful talk. Good luck to you.
Thank you, ma'am.
I thank all the participants for their active participation. The prize winners will be announced later to the individual's mail ID. For further queries, you can contact us in the mentioned number and mail ID. I also extend my thanks to all the jury members. Thank you all.
Yeah, good evening. I just take a minute to thank my wholehearted gratitude and thanks to Dr. B. Sendil Kumar, Dean of the Faculty of Allied Health Science, VMRF, the organizing secretary, Mrs. Kalaivani Madam, the organizers, Mr. Imbasagar and Ms. Ragita Ramesh, and other faculties of VMRF. Thank you all for giving us an opportunity to assist the session, and it was a wonderful experience to us too. Thank you all.
Thank you, ma'am. Thank you for accepting our invitation.
Thank you.
I just let me conclude also. It was a very good experience for me. The first time I have been seeing the oral presentation in the virtual thing, and there are more students have given more opportunities also. It is a very good podium also. I would like to thank the organizing committee, and it was been nicely organized and it went very well. Very good luck for the future careers also. More events also to be conducted for the team. Okay, congratulations and special thanks to the host, both the host Ragita and Invasagar. It went up very well. Okay, thank you all.
Thank you, ma'am.
Thank you.
Thanks for accepting our invitation. Thank you, dear participants. Thank you. End meeting for all. That's it.